Good morning and welcome to the 7th meeting of the Criminal Justice Committee in 2026. We have apologies today from the convener, Audrey Nicholl, MSP. We will also have two members attending remotely. First of all, Michael Matheson, who will be the SNP substitute for agenda items 1 to 3, and Fulton McGregor, who will attend remotely throughout. Agenda item 1, colleagues, is a decision on taking business in private. So we have to decide whether we're going to take item 5 in private. Are we agreed? Thank you, we are agreed. Our next item of business is an oral evidence-taking session on an affirmative instrument. This is the Antisocial Behaviour Fixed Penalty Offences Miscellaneous Amendment Scotland Order 2026. And we are joined by the Minister for Victims and Community Safety. And I also welcome to the meeting Robert Wiley, the Policy Lead for Safer Communities, and Nicola Guild, Legal Directorate of the Scottish Government. I refer colleagues to paper 1 and intend to allow up to 15 minutes for this evidence session. Minister, may I invite you to make some opening remarks and set the scene on this SSI, please?
Yes, good morning, and thank you, Convener, and good morning, Committee. Thank you for the opportunity to address the committee on this instrument, which makes targeted, proportionate updates to the Antisocial Behaviour Fixed Penalty Notice, also known as ASB-FPN regime. The regime enables police to respond swiftly and appropriately to low-level antisocial behaviour, ensuring meaningful consequences, level antisocial behaviour and meaningful consequences. Apologies, Convener. Fixed penalty systems are well established, and the principle of this regime has not, to my knowledge, been questioned in Parliament. The draft order makes 3 updates. First, it removes 2 offences that were not issued ASB-FPNs in the most recent year of available data, helping keep the regime focused on offences for what it is actually used. Secondly, it adds threatening and abusive behaviour under Section 38(1) of the Criminal Justice and Licensing Scotland Act 2010. Section 38 is now routinely used for lower-level threatening or abusive conduct, and in its inclusion aligns with the ASB-FPN regime with current policing practice and with the recorded police warnings, which Section 38 is already eligible. Thirdly, the order uprates the penalty fine from £40 to £70. Using the GDP deflator, £40 in 2005 is equivalent to around £68 today, so the new level restores the original term's value. The wider review of antisocial behaviour legislation will give ministers in the next session the opportunity to consider more substantial reforms. In developing the instrument, officials engaged with the Crown Office, Procurator Fiscal Service and Police Scotland. The Lord Advocate highlighted the strengthened guidelines on police direct measures, which sets clear limits on ASB-FPN use and require consideration of victim impact and provide for monitoring, audit and annual reporting. Police Scotland are also working with Community Justice Scotland on a new referral and signposting pathway for first-time offenders, aimed at reducing reoffending expected later this year. Overall, these amendments update an established regime operating within a framework of safeguards and oversight. I understand the Delegated Powers and Law Reform Committee considered this instrument on the 27th of January and raised no points, Convener, but I am happy to take any questions.
I'm very grateful to you. I have a couple of questions and then I'll throw it round to colleagues. The instrument proposes to add Section 38(1) offences, as you've just detailed, Minister, to the fixed penalty notice scheme. Now, that creates an overlap with common law offences of breach of the peace, which is already part of the FPN regime. So, Minister, what evidence can you adduce that adding Section 38 is the right thing to do here, given that overlap? And in practice, how should that overlap be dealt with?
So thanks, Convener, for that. And I might bring in Nicola just for the legal side of things there. But this was done under discussions with Police Scotland they always said they would welcome if they could use Section 38 with a fixed penalty notice. And that's why we've been able to introduce it there. I think with how the police would enforce it and how they would use the difference would be up to the guidelines from the Lord Advocate's guidance on fixed penalty notices. But I might bring in Nicola if you want to add anything further.
Thank you, Ms Brown. Yes, I'm not quite sure I really understand the question, but I suppose there is an element of overlap between the two offences, which already exists. I'm not sure that the inclusion of Section 38 in the fixed penalty notice regime is any different to how it would operate otherwise at the moment.
My question then, Nicola, was around the currently breach of the peace. Section 38 does something that breach of the peace currently does, but breach of the peace currently is part of the fixed penalty notice regime. Therefore, by adding Section 38(1) in, you've now got two, except breach of the peace common law will not be legislation, but you have two effectively legislative processes which amount to the same thing. So you have two tracks running, do you not, for the same end?
I think the same applies in terms of the behaviour generally. So the disposal, I don't think, changes the fact that they are two separate offences. It's really just making sure, in the same way that, for example, a person could be reported to the Procurator Fiscal for either offence at the moment, the police would use their discretion in terms of what the person is charged with. The same would apply in terms of issuing a fixed penalty notice. So it would depend on the facts and circumstances of the case and whether or not the behaviour constitutes a Section 38 or a breach of the peace.
Thank you. Minister, the sum is being raised from £40 to £70, and the thought behind that is that this will provide a deterrent. What evidence do you have that £70 will actually provide that level of deterrent that Parliament originally intended?
So firstly, it's not being risen for a deterrent. I think we accept there's some sensitivity about the £70 penalty could be perceived also by some that it hasn't gone far enough. But what we're doing is, because this legislation hasn't been updated in over 20 years, we're just bringing the price up in inflation. But as we move into the next parliamentary term with antisocial behaviour legislation, this is something that I hope would be reviewed annually instead of every 20 years. So that the fines that we're bringing in here are just bringing it up into inflation. As I said in my opening speech, I think it was £68 if you brought it up with inflation from 2005 to 2026, and that's why we have determined it at £70.
Thank you. I have a further question, but to ensure colleagues get appropriate time, Sharon Dowie.
Thank you. Good morning. Just one question on the two unused offences. They've been removed, so where do those offences now fall?
Sorry.
The two unused offences that have been removed, where do those offences now fall? I think you said in your opening statement there that in the last year of figures they hadn't been used and they're now going to be removed. So where would they now fall? They
could still be charged, as my understanding, but it is being righteous behaviour while drunk in a licensed premises is being removed, and also drunk in charge of a child is being removed as well. So just because there's been no fixed penalties in the last year, it's just keeping the legislation up to date. But the police do have the powers if they want to charge someone with behaviour in those circumstances.
So I'm just trying to get them. They've not used them in the last year, but what would be the reason for removing them rather than keeping them in?
Just because we're just updating
now
legislation.
As a more serious crime, so you would get a more serious offence rather than just getting a fixed penalty.
Will it be up to the police? I think. I don't know, Nicola, if you want to come in there.
Yes, it would be for the police to decide that in the same way as any other offence that isn't covered by this regime.
Right. Okay. And then also in the figures it says that we've got 80% are paid. So of all the notices that are given out, 80% are paid, 20% are not. Do we have any figures on the numbers that are not paid?
So the numbers that I have got is that number of FPNs repaid has been stable over the last 10 years, with around 8 and 10 being paid in full. And this is a figure that's remained broadly consistent over time with inflation, even though it's reduced in real value over time. So it is a matter for the Scottish Courts and Tribunal Service to collect the FPNs, and they have operational independence in doing that. I don't have any specific figures with me, but I'm happy to write to the committee about that.
Right, that's fine. And do you know what kind of crimes are committed for the ones that are not paid? So for the people that are not paying, do you have any information on that as well?
Unless Bob or Nicola have any of that, but I don't have that information.
That would be collected by the Scottish Courts and Tribunal Service as part of their operational work to collect these fines, and we can liaise with them and provide a written reply on that.
Right, so if they don't pay the fixed penalty notice, what would be the further action if they don't pay?
Then it would be up to the procurator.
Just like would they be just written off, so
no,
they don't pay it, or would further action?
I'll bring the legal Nicola in to answer that. It wouldn't be just written up, but I think it would be determined by the procurator fiscal. Is that correct?
So, under the legislation, if a fixed penalty notice isn't paid, it's deemed to be accepted. So the person is deemed to have accepted that, and enforcement action could be brought against them for payment of that fine.
That's fine. And just final question, and I appreciate because it's going, the cost is going up because of inflation, which seems to make sense. But does the government have any concerns that there would maybe be an increase on the number of people that wouldn't pay because of the increase in cost?
No, I don't think that's a reason why we shouldn't increase the penalties.
No, I don't.
Yeah,
I agree with
no, I don't have
the cost going up. But do you
it's...
think that more people will not pay it because the prices went up? Is there a concern about that?
No, there's not.
Right, okay, right, thank you.
Thank you. Rona Mackay to be followed by Pauline McNeill.
Thank you, Convener. This, if I'm understanding this correctly, this may sound a bit of a strange question, but I'm just wondering. So the being drunk in a pub effectively has been removed as an FPN. Is that right?
Righteous behaviour while drunk in a licensed premises.
So what if there was threatening and abusive behaviour in a pub? Is that dealt with?
The police could. It would be up to the police to determine with Lord Advocate's guidelines. But my understanding is the police would still be called and the person could still be charged. They just might not be able to get a fixed penalty notice.
But the fixed penalty wouldn't be applied at that point.
No, that's my understanding.
Yeah. Okay. Thank you. Next, Convener.
Thank you. Pauline McNeill to be followed by Jamie Hepburn.
Thank you. Good morning. It was roughly the same area, but I think you've answered the first question to Sharon Dowie, which is you've removed these two offences because you said that the police are not using them for fixed penalties. Is that right?
They haven't been used in the last year.
In the last year?
Yes.
Oh,
so
right.
there's a.
I presumed it was from 2004.
Pardon? And the year before. Maybe it might be. Would it be helpful for me to just go through some of the stats from the last year about offences with fixed penalty notices?
Yeah, in a second, possibly. Because what I don't understand is 2 years is not a long time, really, in the law. So I just wondered, did you just accept that from the police? We just remove these two offences because they're not being used. They haven't been used for 2 years, so now so they can't now use them. Did you question the police as to why they wanted them removed after such a short period of monitoring?
I might bring in Robert for this.
It's certainly true that we can, if there is a need or a desire from Police Scotland to have these offences integrated into the FPN regime in future, that could be done in the same way as this instrument's doing at the moment. Mm-hmm. I think the motivation behind this change was to clarify and make amendments to keep the regime up to date. And so in a context where for the past 2 years for which figures are available, no offences have been subject to this FPN regime, it feels as though this has fallen into disuse for the moment. That can certainly be kept under review, and as the Minister's alluded to,
that 2 years is the time that you would... I honestly thought you'd say it's not been used in 20 years, therefore I could see that, but
maybe
in 2 years' time...
If I can maybe...
Yeah.
In the last year, the table that I've got from 23 to 24, so righteous behaviour while drunk in a licensed premises was not used. Refusing to leave a licensed premises was used 127 times. Urinating 765 times. Being drunk, incapable 90 times. Drunk in charge of a child, no times. Loud music 43. Vandalism 108. Consuming alcohol in a public place is 1,033, and breach of the peace 1,947, and malicious mischief being 5. So I think it was just sort of looking at the incidents and then determining we're just going to update it and add the section 38 as well for abusive and threatening behaviour, which the police had asked to be added on.
Yeah, I understand. I think for thoroughness, I think if that was subject to me, if that was to rise again, it's maybe we're asking the police why they weren't using them, because that's what I think I understood that they were for. I mean, so that would mean that on those offences, then the police would then charge them then.
Yes, if they were.
And as all the paperwork attached to that, and it could be.
It just no concerns were raised by Police Scotland, and maybe the drunk in charge of a child, maybe. It's maybe something that doesn't happen these days as much as maybe historically. I don't know. I'm just guessing that. But it wasn't that when we were engaged with the police on this was not an issue that they raised. Was an issue for them that they wanted it kept on.
So I just include with this. I would like to think that if that was to happen again, that the government would be more questioning about why the police aren't using it, so that. A committee could make a more informed decision, and simply the police are not using. Well, that's that. Just take it off the. Well, not, because it was there in the first place for a reason, which was meant to be used. So I just make that point that maybe in the future it's worth maybe interrogating the police.
But I think
there's a reason why you're not using it, because what happens if 2 years down the road, as Robert has said, well, you'd like it back, please. It just seems. We're going through all this, and anyway.
I don't know if it's helpful to make the point that a broader revision of the fixed penalty notice regime may be something that the next government might want to consider in light of things like the Sentencing and Penal Policy Commission's report, which suggested different tiers for fixed penalty notices. So some offences would get a higher level of penalty, for example, a little bit like how it's done with penalty notices for disorder in England and Wales. So there may well be an opportunity to come back and look more broadly at this in Parliament. Certainly for our part as officials, we are reviewing the whole of the Antisocial Behaviour, etc. Scotland Act 2004 right now. And so that gives an opportunity to tease some of these points. This instrument, as the Minister's outlined, is just trying to bring up to date in line with current practice, but certainly we're engaging with Police Scotland as part of that review.
Thank you, that's very helpful. Thank you.
Jamie Hepburn.
Thank you, Convener. We've just got to be a little cautious when we're talking about removing offences. Well, that's what we're literally doing in terms of this process here, but people out there might suddenly be thinking these offences won't exist anymore. But, as the point has been made, they clearly still exist in law and have legal effect. I suppose the question might be then, if there hasn't been any fixed penalty notices issued, are we aware that people are still being charged under these offences? Is that still happening?
Well, my understanding, no, but I don't know if Robert's got any...
Not through the fixed penalty notice, sorry, out with the fixed penalty notice.
Well, it wasn't an issue that's been raised with Police Scotland with myself, but maybe conversations with Robert.
It's certainly an offence that can be prosecuted, and this instrument doesn't change that at all. These offences...
I understand that. That was the basis of my question. Are we aware of whether or not that's happening?
I don't have the figures myself to hand available, but I can certainly write with details of...
I think if it was a concern and people were still getting charged, I think the police would have raised it in our discussions, and it wasn't an issue that was raised with Police Scotland regarding that. But we're happy to write to the committee regarding that.
No, that would be helpful. It would just be give us wider context in terms of the utility of these offences, just generally. Just in terms of, I suppose it picks up on Pauline McNeill's point. This maybe relates to the point that Robert's just made. Robert referred to officials, as I would expect them to be doing, continually keeping these things under review. Maybe just understand a wee bit more about the work that's been taken forward in that regard, but just in terms of the point about adding or removing offences that could fixed penalty notice could be issued. I mean, presumably it's as straightforward as the process we're going through right now. Just be another affirmative instrument.
Yes, so this is something, as I said, just in conversations with police, they've said this would be really beneficial for them. So it's something that we've been able to do through this secondary legislation in this parliamentary term. Moving forward to the next parliamentary term, and we all appreciate the issues that we have with antisocial behaviour. There was an independent review report that came out last year, and we've been working with COSLA at Police Scotland regarding the recommendations of that review, and one of the things is to review the fully antisocial behaviour legislation, so that would be for the next government to be doing, which I hope would be taken forward.
Okay.
Sharon Dowie has a further question.
Yep, sorry, just to come back in on that point again about the 2 offences that are getting taken out. And it follows on probably from what Paul McNeill has said as well. It's only in the last 2 years that the offence hasn't been used. And again, it's a tool in the toolbox. So if you take that away, then the only option left thereafter would be to do an actual charge, which would then take up police time, paperwork, court time. I just think, I still don't understand the reasoning why we would take it out. Would we not be better to keep the charge in so that the police can use it rather than take it out, and then the only option after that is to then have more time spent in courts or with prison sentences?
I might bring Bob in, but it wasn't something that Police Scotland asked to be kept in, so that's the only reason that we've removed it.
I think it's important to make the point that a report could be made to the Procurator Fiscal, but the Procurator Fiscal may decide on direct measures that don't involve court appearance or anything of that nature, including things like fiscal fines. So it isn't automatically the case that just because we're removing this from the fixed penalty notice regime that court proceedings would ensue as a result. I think it's also maybe helpful to make the point that the fixed penalty notice is one of 2 types of direct measures that can be issued by the police. The other one is a recorded police warning. Both are subject to the Lord Advocate's guidelines setting out in what circumstances they can be used. The 2 offences that are being removed from fixed penalty notices can't be given recorded police warnings. So again, this is, in that sense, bringing consistency into the regime. But it's certainly, as the Minister's outlined, a point that we can look to continue to clarify and discuss with Police Scotland as the review continues. And as the Minister's outlined, if there is an issue that the police would wish for this to be introduced into the FPN regime in future, then we can look to do that.
It just seems to be adding more paperwork onto a system that's already under pressure. So I still don't understand the reasoning why we need to bring it out. It could just be kept in, and I don't think it would make any difference. So anyway, thank you.
Thank you. If no other members have any questions, Minister, I just want to clarify something with you. In response to my second question at the start, you told me, I think, and I'm just paraphrasing what I think I heard, was that this wasn't, raising the £40 to £70 wasn't about deterrent. However, the Scottish Government policy note into this SSI says at bullet point 3, without revalorisation, it no longer provides the proportionate deterrent originally envisaged by Parliament. So that would seem that this is about deterrent. Yes. I wonder if you might clarify that.
Yes, apologies, Convener. Maybe I was taking your question as the only reason we were doing this was as a deterrent. Of course, all fixed penalty notices are a deterrent on the round of everything that we do, but we were just trying to bring up the fine with inflation since 2005.
Very grateful. If there are no further questions, then our next item of business is to consider a motion to approve the affirmative SSI on which we've just taken oral evidence. And for good order, I remind officials that only MSPs may speak in a debate on a motion. May I invite the Minister to move motion S6M 20475 in her name and make any brief additional comments that you wish to make.
Thank you, Convener. I move the Antisocial Behaviour Fixed Penalty Offences Miscellaneous Amendment Scotland Order 2026 to be approved by this committee. And I've got no further comments. Thank you.
Very grateful. Do members have any points that they wish to make? Pauline McNeill.
I think it's important just to draw out that what we've heard this morning is that for two offences that are being removed from the list, this is on the basis of monitoring over a 2-year period, which I don't think is that long. Also, I made the point, I think that, I mean, I'm not going to vote against the motion on the basis that, as what the ministerial team said, that, well, it's easy enough to bring it back. But I just think in the future, I think a longer period and maybe more interrogation of the police who are the ones who are asking for it as to why they haven't been used, because I think Sharon Dow made the point that the whole point of fixed penalty notices is that if the police think it's appropriate not to charge them, which does involve as a more formal process and does go to the fiscal, albeit for the fiscal to decide whether that's going to proceed or not, for lower level offences. So you wouldn't want in future to be a back and forward. We're not using that. We're using this year, but not. But I mean, I'm not going to stand in the way of it, but I just think that it's maybe important to draw that out for future reference. Thank you.
It's an interesting point. Do any other members have any contributions? And if not, I will invite the Minister to wind up to perhaps respond to the points that have just been made and press or withdraw the motion.
Thank you, Convener. And I press the amendment, and to Pauline McNeill's point, I take those on board. This was just through bringing this forward was with discussions with Police Scotland with what they thought would be beneficial. So they have been engaged. And I said any further changes moving forward to the next parliamentary term would have a broader consultation as well. But I'm happy to write to the committee on further figures regarding those two offences.
I'm very grateful. The question then is that motion S6M 20475, that the Criminal Justice Committee recommends that the Antisocial Behaviour Fixed Penalty Offences Miscellaneous Amendment Scotland Order 2026 be approved. Are we all agreed? We are agreed. In which case, are members content to delegate responsibility to myself and the clerks to approve a short factual report to the Parliament on the affirmative instrument? Yes. Thank you. We are agreed. So that will be published shortly, and we'll now have a short suspension before we move on to the next item of business. I thank the Minister and her officials. Thank you. Thank you and welcome back. Our next item is a series of panels looking at one of the committee's priorities, which has been for this session, namely the policing of mental health. This means how Police Scotland look after vulnerable people in the community, including people in mental health crisis, and also looks how Police Scotland are looking after its own officers and staff, including the issue of police suicides. I refer members to paper 2 and welcome for our first panel Stephen Gallagher, Director of Mental Health, and Dr Robbie Steele, Principal Medical Officer for Mental Health of the Scottish Government. You're both very welcome this morning. We have up to 60 minutes for this session. So can I start by inviting either Stephen or Robbie to make a short opening statement, please?
Thank you very much, Convener. I'm grateful to have the opportunity to attend today in my role as Director of Mental Health in the Scottish Government to respond to the committee's questions on mental health and policing. My colleague, Dr Robbie Steele, is also here today as the Principal Medical Officer for Mental Health at the Scottish Government to offer clinical expertise and insight. Since the committee last took evidence on this topic back in January 2025, progress has been achieved in a number of areas, and I'm sure the session will provide the opportunity to get into the detail of that. I'm pleased that this has been achieved through collaborative work of the Mental Health Partnership Delivery Group to help improve our emergency and unscheduled care mental health pathways. Mental health service reform is a priority for me and the Mental Health Directorate, and working collaboratively to ensure that people in distress receive the right support and the right place at the right time, and tackling unnecessary demand on policing is a critical part of this. As committee members will be aware, mental health and distress are multifaceted issues that require an effective whole-system partnership response. A range of factors can contribute to our mental health and well-being, including poverty, employment, housing, our communities, and many more. And that's why I'm pleased that our partnership approach to deliver improvements includes the Scottish Government, Mental Health Services, COSLA, Health and Social Care Partnerships, the Scottish Police Federation, Police Scotland, the Third Sector and others. Thank you very much, Mr Convener.
Thank you. I'm very grateful, and I'm very grateful for the submissions to all panellists, but yourselves that have been sent in. I'll open with a quick scene-setting question before I move to Sharon Dowie. But, Stephen, tell me this. In the papers, since 2021, the Scottish Government's provided £84 million for grassroots projects. The Partnership Delivery Group, I think, was set up in December 2023. We have a framework for collaboration, which I'm less clear on the date, but I think might be 2021. With a June 2024 Mental Health Task Force. This committee starts getting particularly interested in this in about May 2022. So what actually has been achieved, but perhaps more importantly, given the evidence that we're going to hear later today about the significant challenges that are still out there, when are we going to get to a situation where, if you like, the right agency is dealing with the right people at the right time?
Thank you for that, Convener. Just firstly to say that the framework for collaboration was published in February of 2025, a month after your last committee meeting, and with that came the collaborative commitments. Of course, that is a journey of improvement, and you're right to highlight that journey has taken place over a period of time. Let me just for a moment set the particular issue of partnership working with the police and the various systems and handoffs that are appropriate there. Let me just set that within the slightly wider context of what we're trying to achieve in terms of the mental health and well-being strategy, where we have a focus on anti-stigma and stigma reduction, where we have a focus on prevention of mental ill health and support of people and communities, as well as then improvements to services. And yes, you're right to highlight that there's been significant investment over a period of time across that whole spectrum of the mental health service offer, if you like. So when we talk about prevention, and that is an important aspect in all of our work, we have invested £164 million split between investment for services for children and young people in the community. That money is now, part of that money, £15 million per year, is baselined into the local government settlement, and £15 million through third sector organisations, through TSIs, through the interface and then down into local communities to support adults with their mental health and well-being. So prevention is a really important part of our work. Then we move on to issues such as anti-stigma reduction or stigma reduction, and you will be aware of our campaign work with SAMH in terms of See Me and the impact that that has had in reducing the stigma around mental health. And then, of course, there is a significant development agenda for services. So in the period that you mentioned, Convener, taking us back to 2020, we stood up the Mental Health Hub within NHS 24, and within recent years we have extended that to 24/7 coverage. That now reaches 10,000 people a month, over 120,000 people per year, use that as their gateway into mental health service provision, which didn't exist previously. The schemes that I mentioned on prevention, just in terms of adult prevention, reach 300,000 adults in Scotland per year. And the latest figure for children's services is over 60,000 children who receive support through Children and Wellbeing Support. So we have been developing services as part of the implementation of the mental health strategy, as well as working through the interfaces between existing services and new services that we have established. And yes, that takes time in partnership working to identify what can be improved and then to work on those improvements. And that is what we are committed to doing. And what have we achieved in that? Well, I think I probably touched on a few of those achievements in terms of the establishment of the Mental Health Hub. I haven't mentioned yet, but I know it's contained in Caroline Lamb's letter to you, the creation of the Enhanced Mental Health Pathway, which connects Police Scotland to the Mental Health Hub. The activity of that per month is around 300 to 350 calls per month go from Police Scotland contact centres to the Mental Health Hub, and then there are a range of services that can be accessed from there. We have stepped up our through a programme for government commitment this year in 25-26. We have a commitment to expand the offer of the Mental Health Hub to allow direct access to psychological interventions, and we hope that that will allow another 1,700 type interventions per year in that way. We have supported the establishment of safe spaces, and I won't go into detail on that because I know that you spent some considerable time as a committee talking about the safe space approach. At your last meeting, we've resourced triage car services with Scottish Ambulance Service in Inverness, Dundee and Glasgow, and those are currently being evaluated. We've reviewed psychiatric emergency care plans. We have completed the review of those plans as at December. We are now working on the guidance to go to partners and the NHS. And our distress brief intervention programme, which is a key facet of some of the support that we can give people who appear in distress, has reached a landmark 100,000 referrals. And incidentally, the community model of distress brief interventions achieves a 9% referral rate from frontline policing. And policing can also access distress brief interventions through a national pathway, and that's available through that transfer between the Police Control Centre and the Mental Health Hub. And over 2,000 frontline police officers in Scotland have been trained at level 1 distress brief interventions. I could go on, Mr Convener, but I hope that gives you a flavour of some of the improvements that the mental health strategy has brought over the last 6 years that you reference.
Yes, it certainly does, and I'm grateful. I'm not sure it quite answers the point about when we will get to a place where the police are doing the right people, right place sort of thing, but I know colleagues are very interested in that, so there'll be an opportunity. So I'll go to Sharon Dowie, followed by Pauline McNeill, please.
Thank you. Good morning. You've mentioned the framework for collaboration, and it says that you're promoting a multi-agency collaborative approach to improving local distress pathways with the person-centred, trauma-informed and no wrong door principles at the heart of the improvement. And it all sounds really, really good, but the Scottish Police Federation say that the handover between police and health functions is at best broken, at worst non-existent. So what is it we're doing to address that problem? right now, because we seem to be having lots of meetings, we've got lots of groups, but the police need action right now so that there's a handover, especially at hospitals, 24/7, not just Monday to Friday, 9 to 5. So what is it you're doing just now to take the pressure off the police force so that somebody who has a mental health problem, you're trying to reduce stigma. I don't think stigma will be helped with them being held with a police officer. They would probably much prefer being with a health professional. So what are you doing to address it just now?
So maybe if I could start with something that we launched back in 2024, which is called the Community Triage Index, or sometimes referred to as the Mental Health Index, which police officers currently use and have been using. There are some really good examples of progress which has been made in the use of that, but it allows police officers to access on a local basis a member of the mental health team 24/7. I think Chief Superintendent Patton may have spoken to you in the past about the particular success of the approach in Lanarkshire. I wonder whether Dr Robbie Steele might be able to say a little bit more about how that tool operates and a bit just about clinically how that handover happens between professionals.
Yeah, the police being called by the general public in what is the lay concept of a mental health emergency hasn't gone down dramatically. It's it's plateaued and it's coming down. But I think that's probably going to be the last thing that changes to change, you know, the public's behaviour and awareness of what options are available. People still phone 999 and ask for the police when they're in an emergency. So where real progress has been made over the last few years, and in particular last year since the collaborative was established, is the options available to the police once they've been called. And the enhanced mental health pathway allows the police, once they've got that call, to say, actually, you're better dealt with by the NHS 24 hub. And the data shows that that's saved 70,000 hours of police time already. And there's only data available for the last 10 months, but the last 10 months it was 17,000. So it's over 20,000 hours of police time a year, just that one initiative. The second thing is the DBI, which is now brought across Scotland, which again is access all over Scotland. It gives the police an option that isn't take the person to A&E or get them a mental health assessment, but it's this person would probably benefit from support and advice on how to manage their own distress more effectively and what the root causes of that distress were. And that's now up to 100,000 people. It's helped. The issue of police arriving with someone at A&E or the mental health assessment service and how do they hand them over? There's a very good pilot going on in Lothian at Royal Infirmary A&E of how the guidance for police officers can be operationalised and how the handover to clinical staff can be documented and explained. That pilot's still to be evaluated. It will be, the evaluation is happening at the moment. It'll be published this month, but that it's not perfect. It's a first attempt at it. But I think that has the potential of being rolled out. And for police officers, the ability to structure why is it not appropriate for me to continue staying with this person? Why is it appropriate for me to hand them over to the clinical staff? Is that well documented, the rationale behind that? Are the clinical staff aware that the patient's been handed over, that the police are leaving? That has the potential to save, to really improve that interface. It's never going to be perfect, but it's got the potential to really improve it. And I happen to know the people at Lothian who've been involved in that pilot, and it's very promising. So there's reasons to be optimistic. The collaborative is coming up with real solutions that are making an actual difference on the ground, even though it hasn't yet really translated much into stopping people from phoning the police as their first point of contact when they're in crisis. I hope that'll, as what's available increases, that behaviour of the public will change in response to what's awareness of what's on offer.
Right, so you've said about pilots and trials. You spoke about Lanarkshire. There's a pilot in Lothian just now, but if the police get called, they will go to the call. So I'm more interested in what the NHS, we already know it's an issue, it's been an issue for years. So it's nice that we've got pilots just now, but this is not a new problem. So in you mentioned the community triage guide, and it sets out 24/7 access arrangements to mental health unscheduled care clinicians in every locality across Scotland. But we're not seeing that in the ground. So the police are still saying that they're getting called and there's no handover. So what is it we're doing? I still don't understand what NHS is doing now, so that if the police go to a call and it's a mental health call, there's no risk to life, the police don't need to be there. What have the NHS put in place so that the police can safely walk away from that person and leave them in the hands of a clinician?
So if I could just respond to that. So the 24/7 access point that's been created.
It's being created. It's not created yet.
That is created.
It is created.
But right. What I will say to you is that the practice is not yet consistent across the country.
And why is that?
And that will be for a variety of reasons in terms of how different services are configured. So Dr Steele's explained to the committee what is currently working, been tested in NHS Lothian. There are different models which apply in different parts of the country. So let me just give you a brief example. NHS Lanarkshire, the contact would be with a psychiatric liaison nurse. There would be a protocol with a commitment of a response within a period of time. And then, based on an assessment, the person would then be directed to the best available point of care for them. What we have agreed to do as part of the collaborative commitments is to resource a quick review of practice around the country so that we can look at what's working and then what we can roll out. And that work will take place through the Mental Health Collaborative, Unscheduled Care Collaborative that Dr Steele referred to. So we have facilities in place, or we have services in place 24/7 across each health board area in the country, but the way in which that is done is variable. And what we're trying to look at, what is working, what could work better, and is there a standard model that we could apply across the country? And that is a commitment within the collaborative commitments and within the delivery plan that we're currently working on.
Okay. Yeah.
Thank you. Pauline McNeill to be followed by Rona Mackay.
Thank you. Good morning. And thank you for your introductory remarks about all the work that you're doing. I think it's really useful to hear. It's just a continuation of the lines of questioning that Sharon Dowie, because from the perspective of the Criminal Justice Committee, what we are hearing is more than any other reason, more than police officers waiting in court, this is the singular issue that is taking up police time, so it has to be resolved. I think we all agree that. Can I start by talking about the pilots or the hubs? So in those cases where police officers, so they get the call and they take the person to, if it's a Lanarkshire facility, do they hand the person over and do they walk away at that point? And does that mean that the NHS looks after that person from there on?
So, again, I'll defer to Dr Steele on this, but I guess it would depend on the model and what comes out of the assessment, what comes out of the dialogue about the severity of need, and whether it's mental illness or whether it's someone who is in distress but another intervention might be more appropriate, such as distress brief intervention. So I think it would depend on what the nature of the incident was, what the nature of the engagement was with a mental health professional, and then what the diagnosis and the best pathway was for that individual thereafter. In some parts of the country, that could be access to a safe space.
But why does that matter? I mean, if it is an NHS issue, regardless of the... Surely, when the police officer takes the person to the NHS facility where they are best to be treated. Why would the police officer not just say, well, we've done our job, so over to you? Why wouldn't that be the case in every circumstance? Because what you're saying is that you think the police have got some responsibility at that point to wait and find out the diagnosis.
A year ago, I was in front of this committee with a different hat on. I was here as a professional, just as a liaison psychiatrist, who works in an emergency department. Now I'm here as principal medical officer, as the psychiatrist who advises the Scottish Government. The point I tried to explain last year, I don't know how well I explained it, is that there are two competing models of mental disorder. There's the medical model, which looks at serious mental illness. Your brain isn't working right. You might have schizophrenia or bipolar disorder, whatever. There's then the lay understanding, which is of mental disorder, that this person isn't either, they're not able to control their emotions, they're not able to control their behaviour, often in response to life events that have happened more recently. The problem is that the general public, understandably, followed by and large a lay perception, the moment the behaviours, they contact the police. The police bring people to the NHS. The NHS appropriately deals with a medical model, largely a medical model, and there's that gap in between, the people who are struggling to control their emotions but don't have a major mental disorder. The NHS tends to say, well, they're not ill. The police says, well, but they're not behaving as their usual self, and there's that gap that they fall between. Now, ultimately, the solution to that is in the safe spaces area, is in emergency provision for people in emotional distress. So provision universally that follows the lay definition of mental disorder. Actually, we're working on that. That will take a shift in the mentality of what we provide for people in distress that isn't purely based upon an NHS model, but involves a holistic approach across services. Someone might be in distress because their relationship's broken down. They might be in distress because of debt, because of housing problems, because of substance misuse problems. We need services across Scotland that will embrace that broader definition of mental disorder, and it's not clear that the NHS is where that should sit.
So does that mean that no progress has been made then in the gap? Because you're talking about, to me, something intangible at the moment.
No, I'm talking big picture. We bring it down to the small picture. At the moment, people contact the police when they're in distress. What we've really worked on is the options available to the police. They have the enhanced mental health pathway now. They know who to contact, and they're guaranteed they're going to have contact with a mental health professional in their area. We're trying to improve the robustness and the consistency of the handover from police to clinical staff when they hand them over. But ultimately, it's people in distress. The service for people in distress is variable across the country, and that is something that I think in the long run is a societal issue, and neither.
But it's not a police issue. But this is what I'm struggling with.
Yeah.
Do we agree here? It's not a police issue. Oh. And you're saying it's not an NHS issue.
So, the NHS doesn't view it as an NHS issue.
Right.
But and that's where people fall down. And at the moment, in some places, there's very good provision. If we go to Tayside, there's the Nuke, there's Hope Point, there's the Beacon, all of which are only open 12 hours a day, 7 days a week. But they are places that you can go when you're in crisis and where your distress will be contained and where there's likely to be a solution found for the problem that led to the distress. Can that be replicated?
I don't feel we're getting anywhere, to be honest, with what you're saying, because you said in your submission the task force is looking to build training to give officers and staff the knowledge and skills and confidence to support that balance around the care and support and monitoring and day-to-day policing. It sounds to me as if you're still going to rely on police officers to fill that gap.
How have we ended up in, I mean, this committee is looking at how we've ended up in a position where the police are the first point of call, and the police will tell you they're filling a gap in provision. what the health and police can do, or mental health service and police can do on their own, I think they're really increasing the options that the police have. They're, I mean,
right, well, I don't really understand what you're saying, if I'm perfectly truthful.
Okay.
Right,
Things like,
so, okay, please. So when you say that, so the work that you're talking about, that where you've scaled it down, so we're making some progress, that is not the gap area. It's where people have got a mental, the two competing models, if you like, where they've got a mental health problem, a diagnosis that needs to be. That's where you make progress. Is that right? But not where the gap is.
Things like distress intervention are exactly where the gap is, and are, you know, they've helped 100,000 people so far. The enhanced mental health pathway.
But I'm not asking you that. I'm not. I'm asking. You said you've helped. I know you've, and I commend all that work. What we really want to know, because this is our role, and you have your role, we have our role. What we are trying to ascertain here is you've all these people you've helped. At what point then can the police officer walk away and give that response? Because it's not their job to deal with something they're not trained to do. Although that's why I'm confused about the submission where it says that you're looking to build training to give officers the staff knowledge and skills and confidence to support that balance. Feels like we might be back to square one. That's what I'm trying to ascertain is what progress has been made in allowing police officers to go and do their jobs.
Yeah. I'll just say that the mental health, enhanced mental health pathway allows people, that allows the police service, when people contact them, to redirect people to NHS 24 directly without getting involved. We've done, both the police and the NHS have made good progress in enhancing handover and getting the police, as you say, out of the case earlier, saving police hours. The reason I'm pointing out the gap is I do think that ultimately there's a limit to the extent to which the police and the NHS working together, solely working together, can solve this problem. It's a broader societal problem. But actually, I think there's the appetite there to change the nature of the services that we have, so that we, with safe spaces, etc., so ultimately we do solve the problem. And I've said since I've got involved, the real proof in the pudding is how much time the police are spending on this, and we really we do need to get them out, get the right help at the right place at the right time. And at the moment, yeah, although we've made progress, we've still got progress to make.
Thank you very much.
Thank you. Rona Mackay to be followed by Jamie Hepburn.
Thank you, Convener. Good morning. Just to pick up on a few things and just to clarify a few points that I'm a bit confused about in my head. So, Dr. Steele, you said, I think, that police, as part of the progress made, police now have contact with mental health professionals immediately in their area. Is that 24/7? So any time, right? That's fine. And what training do when police get the call and say, well, I need to redirect this? What training do they have to make that assessment that it does need redirected?
A lot of police officers train in what's called distress brief intervention phase 1 training, which is where they assess and can tell whether the person is suitable for that, and that's one type of training. But the fact that they can contact a mental health professional 24/7 wherever they are and seek advice and run the case past them actually is probably the most important development. It places less onus on the individual police officer to make judgments. They can get advice and support immediately.
And is that happening in every area, or is it a bit of a postcode lottery? Is it?
Sometimes it's not immediate, simply because the contact is to an individual clinician who might be dealing with another case. So sometimes there's a bit of a wait. I'm not going to pretend that there's always someone on the end of the phone. That there isn't. But it's that route is available everywhere, and it's well resourced, and it's, the feedback from the police, and I know the Police Federation want this problem solved immediately, and I have a lot of sympathy for them, but actually they will say it's improved dramatically.
Okay. Thank
if
you.
I could just confirm
Sure.
that distress brief intervention is available in every integrated joint board area across the country. So the service is embedded across the country. And obviously there is a national pathway into distress brief intervention into that higher level, what we call level 2, and that can be accessed through the NHS hub, which again is available to everyone nationally as a digital option.
Okay, I think it was, Stephen, I think it was yourself. There's two things been mentioned, and I'm just wondering if it's the same thing.
Okay.
Mental health assessment service, is that different from the mental health hubs? It's two different things.
Yes, in the mental health assessment services is health board level, nurse run. They're the people who GPs will refer to, police will refer to, people will walk in themselves. Whereas the mental health hub is the NHS 24. You can phone. So once it's a Scotland-wide provision.
Right. Okay. Thanks. So the figures that you quoted are really impressive of the people that have used and been helped by them. And just to get the clear picture of the referrals to the mental health hub come from the police or the assessment service?
Mostly they come from people phoning 111 in distress. But if people phone 999 in distress, the police now have the enhanced pathway, which means they've got direct access to that hub if they think that's the appropriate thing. And the training is in judging whether that's the appropriate thing or whether they need to physically go around. And even if they do physically make the call, they've still got the option of routinely we'd advise you to contact the hub.
Yeah. Okay. You also mentioned that I can't remember the figure, but you said that a lot of children had been helped in the mental health hub. So, what do they have a link to CAMHS? Is it connected?
So, what I was saying, and my apologies if I wasn't clear enough in saying it, is I was referring to community-based supports, which we've invested in as a government for children and young people. And those are services which are coordinated by local government, and we fund those through local government. But as you raised the topic, we have been working with our local authority partners, COSLA, through a mechanism which we call the Joint Strategic Board for a crisis framework for children and young people, so that as we traditionally talk here, by and large, about adults in the space of unscheduled mental health care, so that there is a similar framework that's available for children and young people. And we will be, we hope to launch that framework in the very near future.
So I'm taking from that is a separate service from CAMHS. I mean, I'm saying that because of the big waiting list for CAMHS, and I'm thinking, is this something that could help the waiting list? But it's not. It's a separate initiative from CAMHS.
So the framework will guide children and their families and carers to the most appropriate point of care, which for some may include CAMHS, but you'll also know that in terms of CAMHS access, that for the last 4 quarters, the target of 90% referral to treatment has been achieved. So CAMHS waiting times overall and the size of the CAMHS waiting lists and backlogs have been reducing across the country.
For some assessments, not for all, not for autism. But yes, okay, that's fine. And so, with the new progress that's been made, is there anything you think still needs to be done? Are there any drawbacks to the current system? Or is it very much still a work in progress?
So, I think probably the commitments that are there as part of the collaborative framework and the commitments we've agreed with Police Scotland and other partners are where we need to focus. I do think we have the building blocks which are there. I think there is variation across the country and we need to understand that better. Some of it will be absolutely appropriate because it will be based on either rurality or an existing service model and how you augment that to make sense in a particular locality. But I think our challenge is to scale up what we are now seeing to work and to take that to the next level so that those outcomes are available for everyone across the country even if the service model is a little different to suit a local need.
Yeah, and do you think that can be achieved in the short term? How long is that a long process to get that, you know, balanced out, levelled out across the country, do you think? Is that going to take a long time?
So Robbie, I'll defer to you on this from a clinical perspective, because the change involves changing the way people work and practice.
I've been very impressed with the options available to the police when they're called. I think quite rapid progress has been made in the since this collaborative has been established. I think it's a case of rolling that out across Scotland, improving it. The bigger issue that I was getting to, which is the societal issue of things being termed mental health problems and the expectation that health will solve them when actually it's a more holistic view. That probably needs a change in the way we look at mental health services, keeping the medical model but actually expanding services to embrace the holistic lay model. And that will take an evolution of service which will require partnership with council and local authorities and as well as health boards. We intend to embrace that in what we're calling the target operating model for mental health, which I'm hoping that the next government will support and will go forward. But yeah, Scotland isn't the only country that is experiencing this challenge, but it's the right size to solve it, and the impression I get is that the will is there. But yeah, it will need a reorientation of the way that we approach, and a more holistic approach to, and an adoption of the lay, an overt adoption of the lay model of mental distress, mental disorder. If we get there, the police will have their place, but it'll be the options available to them across Scotland will be massively increased, and they'll be able to really only get involved when it needs police involvement, I think.
Okay, thank you. Thanks, Convener.
Thank you. Jamie Hepburn, to be followed by Sharon Dowie.
Thank you, Convener. It strikes me a lot of what you've spoken about today touches on a much wider response to trying to support people with their mental well-being and their mental health, which is commendable. I mean, clearly that's what the NHS should be looking at, and it strikes me. And you have talked about how it links up with trying to work with Police Scotland to make sure that officers understand processes better, understand options better. That's commendable. That's welcome. But we are here obviously to talk about the impact on Police Scotland. And certainly when I speak to officers that are in my area. Indeed, I just met with local inspector not so long ago, and this was one of the issues that we touched on. The primary concern that seems to be in this area, and we'll obviously touch on this when we speak with Police Federation and Police Scotland, is how much time it occupies for individual officers when they feel that they have no recourse to other than to take a person to hospital. They think that's the most appropriate place to take an individual, and then they find themselves having to wait there for a long time. I know hospitals are obviously very busy places, but I guess the key question there is what more can be done to try and accelerate the process of assessing the individual who's been brought in to see if they need admission, if they need some form of direct intervention or assistance, and if they do, to actually admit them. And I recognise, I go back to the point, hospitals are busy and they're dealing with multiple things, but there clearly is an issue here of occupying other professionals who have a wider job to do, who are not able to get back to that job because they feel they have to wait there with the person they've brought in. So how can that process be improved and shortened?
Yeah, that's very well put. And that problem is recognised. I think the pilot of improving handover and giving structure to the thought process and the decision making around handover from police to clinicians in A&E and in mental health urgent services, the pilot that's happening in Lothian, I expect will be very well received. We'll probably hone it, and I think there is an appetite to roll that approach out across Scotland, and that can be done pretty quickly. So I'm optimistic that, I mean, as a liaison psychiatrist, I would, at 9 o'clock in the morning, go into the medical ward where people who presented after overdose and were receiving treatment were, and very often I'd see 8 police officers sitting there with 4 different patients in pairs, and it always mystified me why they couldn't leave. And you'll speak to the Police Federation after this, but some of it is internal police processes that they're also improving and refining, and that this structured handover will help support the individual police officers in doing that. So I think that's a very good development. But there are some scenarios where it's intrinsically time-consuming. We're not going to reduce this problem to zero. For example, someone's too intoxicated to have a meaningful mental health assessment, but is still very risky and may have gotten a fight in a pub, and there is a crime being committed, and the police want to wait there. And do they sober up in a police cell? That's not appropriate. Do they sober up in A&E? You could argue that's not appropriate. And at the moment, there isn't a perfect.
I think they understand though there will be circumstances. If there's been maybe violence involved and criminal activity involved. It probably is appropriate for the police to wait, because part of that process is to understand can this person then be charged, and how they would then have to deal with it. I suppose it's more, and certainly I'm told and understand that this can be the case. It's where there's no suggestion any criminal activity is involved, and it's really just persons in severe distress, and they might pose a danger to themselves. Is more that situation?
I'm very familiar. I mean, it's very frustrating, or historically has been very frustrating as a clinician. As a consultant psychiatrist, I will say to the police officers, it's fine, I've got this. This person's in hospital, I'm assessing them, please go. So, but our inspector says we can't. We've got to stay. But putting, that's difficult for both sides, but I think putting structure around the decision making, having very clear guidance, and the police, so the NHS meeting the police halfway by accepting that this handover needs to be structured and needs to be well documented and needs to be safe. It's the best thing for the person, but also the police side of things, that them being less defensive in their practice and accepting that handover to the NHS, they have to have faith. But I've heard police officers say, I'm not going to leave them in A&E, because if I leave them in A&E, the nurses won't watch them, and next thing we'll be called to a missing persons call. So I'm better staying here than being called out in half an hour's time for a missing person. And that lack of trust and lack of faith on the other side. Does that not then speak to the point I'm making then? Yeah. How do you get? And I know it's difficult because there are lots of people there in A&E, and it has to be triaged, and some could be there in severe pain, and you need physical pain, and you need to deal with that quickly. I suppose that speaks to the point I'm talking about, because if that's their concern, how do you deal with that process of admission as quickly as possible so that you've satisfied that concern from the police officer's point of view, so that they can say, right, that person's now admitted. I think this idea of a structured, well-documented handover it goes a long way to solving that. It won't reduce it to zero, but I think it'll... No, I appreciate that. I appreciate that. I mean, it's really interesting to hear, and I know, and you'll take this in the sense, I mean, you're giving anecdotal evidence to a certain extent, but of your own experiences, you're telling police officers, this person's now here, they are safe, we can deal with this situation, and they still feel whatever the impediment might be, personal perspective or a structural concern within their own procedures, that they don't feel they can leave. That's interesting to me, and I think that's something we need to explore further, probably with Police Scotland.
I'll look forward to doing that, Jamie. I'll go to Sharon Dowie, to be followed by Fulton McGregor.
Thank you. Just another quick one, coming back onto the availability of service. Have you done any assessment in the availability of 24/7 care? Because I know that you've said that 24/7 care is provided, but there is still the issue with the handover, and it does seem to be a bit of a postcode lottery, and it does seem to happen in evenings and at weekends. So have the NHS, have you done an assessment on what facilities you've actually got available 24/7 to enable the handover? And I just wanted to come back, one of the things that you said earlier was you needed to change the nature of the services you provide and change the way that you look at mental health services as well. And I know everybody talks about the holistic approach, but in a round table that I attended probably over 2 years ago, I'm sure it was a forensic psychologist that actually sat in the round table and had said that some people with mental health problems only feel safe in a secure environment, and it was probably a knee-jerk reaction that we closed a lot of the 24/7 care in mental health. I just wonder whether you have an opinion on that as well.
You can get a mental health assessment anywhere in Scotland 24/7. The health boards actually have a statutory obligation to provide a mental health assessment under the Mental Health Act. So there are mental health assessment services across Scotland. Now, if you live in Highland, that will often be a video assessment with someone at Rigmore, a nurse at Rigmore. If you need physical environment to keep you safe, is the safest thing to take you to Rigmore? Is it to try and provide a safe space somewhere else? So the NHS provides up all night 24/7 assessments. What changes at weekends and overnight is what options are available to those nurses staffing that system. And in Lothian, there's often no beds in the psychiatric hospital. So admitting someone to a psychiatric bed to let them cool off. So often they'll stay in the accidents emergency department. An interesting pilot in Ayrshire and Allen, where they've got adjacent to the psychiatric ward is in the general hospital, but they've got separate space where they can keep people for up to 72 hours just to cool off. And that's been very effective. It allows a safe place where people can be observed, and which without admitting them either to medicine, to an A&E ward or to a psychiatric ward, just a safe place to keep them until they've sobered up and until daytime services are open. Because if someone's got an addictions problem, you need rapid access to addiction support and help, but there isn't a critical mass to make that a 24/7 service. So it's not that in every area that the only thing that's open 24/7 is the mental health assessment service. The nurses, NHS 24 is offering its hub 24/7, but the options available immediately to keep people safe, often they're daytime services. So it can put the clinicians and ultimately the police officers sometimes in a difficult position. Where's a safe place for this person to go?
So I suppose that's what I'm asking. So getting a mental health assessment via video screen doesn't help somebody who may cause harm to themselves or harm to others. So given that we're saying it's a health issue, what are the NHS doing so that is then a clinician's responsibility and the police can do a handover straight away 24/7?
Well, this is where I think it's important to remember the lay concept of mental disorder. Sometimes it is a health issue, and actually those are the easy ones. When someone's got a relapse of the schizophrenia or they're manic, it's quite easy. They need to be detained. You need to find a psychiatric hospital bed for them. They need to get kept safe. The more challenging ones are the people who are intoxicated, emotionally dysregulated, who it's not a health problem. It's a broader. We call it a mental health problem, but it's not what the NHS views as a serious mental disorder. It's emotional difficulties, acute emotional difficulties that will calm down, and what the person needs. I often say the very strong medicine of tea and shortbread, and a safe place to keep them until they're able to make decisions for themselves again, and the emotional dysregulation is settled. And one of the issues with Scotland, as we know, is the very different environments that we're working in. If this happens in the far northwest, it's simply not. There isn't the critical mass to justify having a 24/7 psychiatric facility or even safe space there. It might end up being the community hall or a relative sitting with them in a somewhere where they can be kept safe. But it's a different. The answer in different areas is going to look different. And we've got the triage cars with mental health nurses going out with the ambulance service. That's appropriate in a city. It's less appropriate in the Highlands because you spend all the time driving. So the model of care and the solution is necessarily going to be different in different places. But the fundamental problem is, can we provide somewhere for people to stay safe until they're calm and the crisis is resolved? And there's an assumption that that's going to be a psychiatric hospital. That's not necessarily the best use of a psychiatric hospital. And we've got different models in different parts of the community, and it does need to be developed. And that's a lot of the Safe Spaces work is about that. But yeah.
Yeah, I appreciate the model will be different in different areas,
Yeah.
depending on rurality or whether it's in a city or whatever. But I suppose we're looking to see what progress has been made now. But thank you.
Thank you. Fulton McGregor.
Thank you, Convener. Is that me on mute now? Yep.
Yes, go ahead.
Yep, can you hear me okay? Yep. Thank you very much, Convener, and thanks very much to the panel as well. I mean, it's really just following on from others' line of questioning, particularly probably Pauline McNeill's and Jamie Hepburn's, because this is a situation that we've looked at in this committee for quite a long time, and it's also a situation that very much predates that. You know, it is difficult, and it's a difficult one to get right. But I do agree with something that Pauline McNeill said. I think that, you know, it does feel like things are not really moving fast enough in this area, and I wonder, you know, what are we doing to try something different? And at the last time that you were in to speak about this, I raised specifically the issue of more joint working teams. Now, you've went on to touch on the end of your last answer there to Sharon Dowie a wee bit about the triage system and joint up working happening. But is there any plans to develop almost multi-agency teams between police and health professionals, you know, to respond to these sort of situations so that folks aren't still within their silos? And the reason why I ask that, I go back to my own social work experience, and I know that an area that worked really well was when social work and police worked together in joint teams for the basis of child protection. And that works really, really well when bringing all the multi-agencies in into under the one roof, if you like. And is there any plans to even trial something like that in this situation?
If I could just begin the response to that, and thank you for the question. I think we can very clearly see in our work on safe spaces that there is a benefit in that multi-agency coming together. So in the safe spaces that we currently have, there are 3 in the Tayside region. There's the model which Robbie has referred to in terms of Ayrshire Nara and at Woodland View. These are multi-agency models, and we can see advantages in people being together in the one place and, you know, affecting information exchange and handover and taking a holistic view of all the needs of an individual. In particular, some of them have peer support embedded, which is also another really important feature of mental health support and care. We have this week taken a procurement decision to go out to procurement for a research project which is going to allow us to take an overview of the safe space model and work out how we want to take that forward nationally. So that's part of the service gap which we referred to earlier on. That it's not just about hospital and it's not just about digital approaches in NHS 24. What's that other community space in a joined up way, as you suggest, which we could take forward more holistically across the country, so that every area has the notion of a safe space. As Dr Steele says, based on geography that might look a bit different, but the core principles of how the work is undertaken and how professionals relate to each other, wrapping around the individual, has to be central to that. The second area, which is probably worth mentioning, is that it is our intention as part of the strategic renewal framework for health and social care to establish what we describe in slightly jargonistic terms, I concede, target operating models for the way our mental health system works. And as part of that, we will be looking not just at what happens where, so the conversation we had a few moments ago about access to beds, for example, and Dr Steele saying that the acute pressure that some of our bed base is under, but also looking at what are the other provisions in that spectrum of care that we need to provide, and how would we expect and want people to work across boundaries to make that whole system of care happen. And that clearly is a totally collaborative process. And when it comes to policing, we are all in on a partnership approach with the Scottish Police Federation and Police Scotland. And the collaborative commitments, I think, show that they are also all in on working together to address what is, a really significant change in the concept of how people see their lives and how they approach the public services in a state of distress, as well as the preponderance of mental ill health. Bobby, is there anything you might want to add to that?
Yeah, I'm very glad to hear a question about more integration of services. I ultimately, we need to try and bring community mental health services have been devolved to local authorities under the health and social care partnerships and integration joint boards. If we can do that more effectively so that they are holistic, multidisciplinary services, including social care and health and housing, and lots of peer workers, etc., and persuade them to orientate themselves towards the front door so that there's an open front door and an acceptance that a major part of their work is dealing with people who are in crisis and therefore motivated to change. I think in the long run, that is going to solve this problem. That will become the place that either you go to, or if you do phone 999 and the police are called, that's the place that the police take you to. And yes, they probably won't be up 24/7, most of them, but if they work in partnership with our NHS provision, which is up all night, so that you have, say, a peer worker working alongside your nurses so that they can give the tea and shortbread until the daytime crisis services, holistic crisis services open. I think that's the medium to long-term solution to that. I think if we have that established, we'll find the demand on police will simply drop away. But in the short term, we're doing all we can to partner with the police to fix the things that police and health can fix largely on their own. And I actually am really impressed with the progress that's been made on that.
Thank you, and thank you, colleagues, for all your questions this morning. Stephen Gallagher, a couple of things. Does the Scottish Government believe that the NHS and the wider health system in Scotland has effective provision at the moment to deal with members of the community who are in mental health crisis?
Yes, but I think we would concede that the model in each part of the country will be different. And I think we are committed to making sure that as we go forward, that we have more consistency in our approach and that we follow the principles of the Strategic Renewal Framework around a people-centred approach, a focus on communities, less conveyance to hospital unless absolutely required, support for people in terms of digital approaches, and services which are based on strategic needs assessments. In your question, Convener, you again are asking me a question about mental health or mental illness. I just want to be clear about the definitions we've talked about today, the paradigms we've talked about today. They're very clearly, and I think well described, on page 3 of the collaborative framework, which talks about the different ways in which people present to mental health systems and services around whether, in fact, it's mental distress or whether it's mental illness, and how we navigate the right solutions for people depending on how they present. So if your question to me is, are our mental health services appropriate for those with mental illness, then yes. Have we got more to do on that wider spectrum for people who are distressed in their life circumstances? Absolutely, we have more to do. And as I set out at the beginning of the session, I believe we can only do that in partnership with our public sector partners.
I'm grateful. Police Scotland attend 14.5 or 14,500 mental health incidents every month.
Yes.
And 85% of those don't involve a crime. Now, at the outset, Stephen Gallagher, you told us that there's been a spend of £164 million in this area. Do you have metrics showing what the material impact has been of this spending and the initiatives that you've both described this morning on policing?
So, without wishing to trade in statistics, Convener, I'm conscious that...
I love statistics, Mr Gallagher. Carry on.
Perhaps I've picked a strength. The number of incidents that Police Scotland record as mental health related, based on a full statistical year, I think 23-24 if I'm not incorrect, is about 17.6% of incidents that police are called to. And the key word that will be, as I understand it, inserted in police systems will be either mental health crisis or mental distress or mental illness. But in actual fact, a number of those calls will also relate to other reasons for which the police are called, such as a neighbourhood disturbance, domestic violence, etc. So it's quite difficult to fully conceive of an era where that 17.6% will drop to zero, because there will be very valid reasons for the police to be present at other facets, if you like, of that call and those incidents. Sorry, Convener, can you just repeat the second part of your question?
So it's really around all the spend, all the initiatives. What has that impacted on policing? Have you got any metrics that show me before the spend, police were spending X amount of hours? After the spend, they're showing Y amount of hours, for example.
Okay, so I understand that Police Scotland are continuing to develop quite a comprehensive dashboard of data. So far, they have been able to share with us the level of incidents, and that's what I'm referring to in the first part of my answer there. I do understand that in 24-25, that the number of incidents, even with that broad definition which I gave, fell by 1%. So perhaps there is a plateauing effect going on, but we will obviously see that in the next set of data which relates to the next financial year or the next fiscal year.
I am very grateful to you both. Unless colleagues have any further questions, that will conclude your evidence for this morning. I am very grateful. Thank you for your time, and we'll have a short suspension until 11:06 whilst we change over witnesses. Thank you. Thank you, and welcome back to the Justice Committee session. I reiterate my thanks to the first panel and colleagues. We may wish to write to any of our witnesses this morning afterwards with any points, but we can discuss that after the session. So I now welcome David Threadgold to our session. David is the chair of the Scottish Police Federation. David, you're very welcome this morning. We have about 45 minutes for this session, and I'd like to start by inviting you to make a short opening statement, please.
Thank you, Convener. Committee, it's a great pleasure to be here to present evidence to you today. What I'm going to do is give you an operational perspective on the impact of demand in the areas that are under discussion today, both in the impact of policing as has been discussed in the first panel, and I think it is absolutely right to acknowledge the framework for collaboration. There has been a huge amount of work that has gone on collaboratively between the police and other partners, as well as a huge range of interventions from within Police Scotland. But what I will present to you today is the reality that the operational impact on policing in Scotland and police officers has largely remained unchanged. I have to be honest when I say that after listening to the previous session, I am no more confident now than I was at the start of that session that we are close to resolving the issues that impact on policing at this time to the benefit of those who are trying to deliver policing services across this country. And I think what it comes down to, and when I frame this, it is about what do the public expect from the police? What do they want from an efficient and effective and well-motivated police service? Because I can tell you that the impact of this demand, and it's very telling that it was acknowledged that there has only been a 1% reduction, in recorded calls over 2 years to Police Scotland that relate to mental health. When you consider every other aspect of policing that has increased exponentially in that area, and I talk about reduction in police officer numbers, the protest, policing of protests, which simply didn't exist as a policing demand a couple of years ago. There has to be a solution to this problem, and there has to be fundamentally a change in the way that Police Scotland approach the delivery of policing services if we are to become, or if we are to remain relevant and visible and effective at doing what I know we are very effective at doing in this country. And the second aspect of the presentation to do with Police Scotland's provision for keeping its people well. Again, I do acknowledge that there is a huge amount of work that is ongoing in that area, and I have been part of a great deal of it. There is clearly much work to do, and I've got no doubt that some of those challenges will be spoken about today. And I suppose, Convener, those would draw my opening remarks to a close.
I'm very grateful. We've heard a lot this morning about the good work that's been going on, and you acknowledge that in your opening statement. In our evidence, the Scottish Government have suggested that 20,000 police hours have been saved through initiatives like we've heard about. So that isn't a positive impact, one would have thought, but there is a personal impact on policing, on the individual officers. I think something like, you'll correct me, Mr Threadgold, but I think there's something like 2,300 officers either off or on reduced work at the moment. 20,000 hours saved. Can you help us understand how many hours are the police actually spending, such that is 20,000 a lot to save, or is it a drop in the ocean? And of all the frameworks that you've heard about this morning, all the good work that's been done, has it really not impacted at all, as you seem to suggest?
I'm always very, very cautious, and I look at figures like the police have saved whatever it is, but in this case 20,000 hours, through a different lens, because the police in reality haven't saved anything in that respect, because it was not police demand in the first place. So what I assume these people were referring to is the number of hours that have been deferred, in their opinion, based on examples that they can multiply by a set number of hours that will be sold as a saving to our communities. What I can talk about is the operational impact and the ability for police officers to deliver policing in this country. And when I talk to them, and I do regularly, and this comes from an evidence base of a recent survey that we did, and probably many thousands of conversations with colleagues. Constables, sergeants and inspectors, those who are delivering the service and making decisions about how we close those incidents, will tell me that between 60 and in some cases more than 80% of our operational capacity is lost to deliver policing services because we are picking up the health function. So if that quantifies it, and but in more simple business language, we have a situation that has become accepted where we lose 80% of our core capability to deliver policing because we are doing someone else's work. And I don't mean to be too simplistic. I realise that we're all part of the public sector, and it may come across that I do not have sympathy with the challenges that exist in health and social care. But I am looking at this from a purely, almost selfish policing perspective, because I see every single day the impact that the current model, for what it's worth, has, and the impact on our ability to deliver services, but also on the impact to our staff.
Thank you. You've talked in there about operational capacity and public expectation. And then just right at the end there, you talked about the current model of policing in Scotland.
Yeah.
Now, Section 32 of the Police and Fire Reform Act says that the main purpose of policing is to improve, quote, safety and well-being. Is that reference to well-being an issue? Does that materially impact how the police carry out their functions? And if so, what should be done?
I mean, the simple answer to your question, in my opinion, is yes. It goes without saying that the police abide by the laws that are enacted by politicians, but the presence of the word well-being in that legislation, in my opinion, and again it's evidence-based, although I have been a police officer for 28 years and clearly lived through policing since 2012, the inclusion of that word has allowed policing to get to a position where it is largely ineffective in its role in delivering policing for our communities, and the hook that is always spoken about, it's always referenced through the authority, through the HMICS, through the executive within the service, is that we must do what we do because of the insertion of the word well-being. Now, how that plays out in reality, the strategic direction of the interpretation of that word has played out in the delivery of operational services, in the sense that we now have an absolutely risk-averse structure within the organisation that largely cannot make the simplest of decisions about how it deals with members of our community who are engaged in some sort of health crisis. And an example I'll give you of that last week was the one-year anniversary of the Framework for Collaboration that's been spoken about, and I was at an event for that. There were a number of case studies presented, and one of them was that a female, a lady within our community had been taken to a medical facility by the police. She'd stayed with them during, her care. There was a disposal. And the police then took that lady home via the chemist to collect her prescription. Now, I raise that for two reasons. One, why is it the expectation of health that the police would in any way be involved in that type of activity? And two, how have we got to a situation within Police Scotland where that request is being met by police officers? So it's a good example, I think, of the situation that we find ourselves in, and I am absolutely clear that without a different strategic direction from our Chief Constable that provides first and second line managers within this country to make different risk-positive decisions that will require a different interpretation of the word well-being, in my opinion, nothing will change in policing, and that's something that I simply cannot countenance.
Very grateful. Sharon Dowie to be followed by Pauline McNeill.
The community triage guide that we heard about in the previous evidence session there says there's 24/7 access arrangements to mental health unscheduled care clinicians in every locality across Scotland. I wonder if you could tell us what your assessment is of the availability of 24/7 care.
There's no question that on a piece of paper that statement is correct, but again, the operational reality of that for police officers across Scotland is somewhat different. I asked the question specifically ahead of this session and was told that there are repeated and regular delays in the access to that clinical service to allow my colleagues to make different decisions. And again, it's one of the examples of progress from within our organisation and progress within that collaborative approach. But if I extend the answer, if I may, to distress brief interventions, this is a really positive thing, but it's been mentioned that 2,000 police officers are trained in level 1, so you have that initial highlighting of the challenge, and then there is a 14-day process where that member of the public will get. But if you have a situation where only 2,000, and I use that example because we have many more thousands of operational police officers in Scotland, if we cannot extend that training, if that is the model that Police Scotland want to take to everyone, then those who are trained will feel increased pressure because they are the only ones that can be diverted to those calls. So it is progress for sure, but it is by no means the panacea. And again, Every one of these examples is usually predicated by police involvement in the first place, either physically or on the phone, the police taking individuals to a medical facility or to some other place where they need to be assessed. And it is that time element and that lack of risk-positive decision-making that allows health to take these calls on at the very start that is so prohibitive in our ability to deliver policing.
Is there still an issue with accessing help out with normal working hours, so like Monday to Friday, 9 to 5? Is there any kind of pinch points in evenings or at weekends, or has there been improvement made in the last
Usually
couple of
about
years?
5 o'clock on a Friday. But no, not to joke. You know, there is, the services are available notionally, 24/7. But again, talking to colleagues, the service does tend to drop off out with what we would class as business hours, Monday to Friday. And again, at that event last week, I was struck with the systems that exist within health, and I really want to keep this focused on the police. But whilst we have 14 health boards, 32 local authorities, and from speaking to health colleagues at that event, computer systems within social work that cannot speak to health, these problems do not help the police when trying to get information to make risk-positive decisions about individuals within our community. It was spoken about the pilot in J Division, this transfer of care, that and somehow that can be implemented nationwide in the next month or so. That is simply not the case. That change in working practice would require consultation with the Federation and a huge process to be go through governance within the organisation. So whilst again I accept that in principle the ability to ask a number of questions of an individual and have a clinician or a doctor there to say this person is safe to leave here is progress, the reality even from within that pilot is that the availability of medical practitioners to sign off on the health aspect of that is restrictive, and as I say, by no means is this something that is going to be in place quickly.
Are there any best practice models? I think in England there's a right care, right person model. I don't know whether you're aware of that or not, but is there anything that we could learn from other places that we could bring in that could be implemented quickly so that you can see the benefit?
Both the police and the government have said that Police Scotland will not adopt the right care, right person approach. Which does everyone know what that is, or do you need?
It would be helpful if you actually explained it very briefly.
Okay. I mean, very briefly, they will take far more risk-positive decisions based on the information that they have, from people who are in some sort of crisis. The example would be that I was given was if somebody calls the police down in England, and it's only in certain areas of England, and says, I feel suicidal or I have not been for dialysis, they will divert those calls immediately to a general practitioner of health. In Scotland, we might take a different approach to that call and send police officers to it. Very simply, that is it. But it is a far more direct and almost selfish, and I use that word quite carefully because I don't want to appear to be, playing a role in the public sector approach to the way that we deal health, simply because of the demand and the impact that it is having on our ability to deliver policing.
So has that been selfish, or is it just directing the call to the correct person that should be dealing with it?
It might involve saying to that person, thanks very much for phoning the police, however, this is not a police matter, I ask you to divert your call to health, and putting the phone down, to be blunt about it.
Right. Okay. Right.
Many thanks. Pauline McNeill to be followed by Rona Mackay.
Thank you very much. Good morning. Yeah, I know you were sitting in for the previous session, so you heard it all. I have to say it was kind of difficult to discern what the NHS thought was the problem, but I think we got to it, which is, to me, my reading of it is they're saying there's a gap and it's no one's responsibility, so it falls to the police. Just wondered what you thought about it.
I mean, that was acknowledged by the HMICS in their 2023 report, and it is very much the view of the police that we have become, operational police officers, that we have become the service of last resort, and that risk aversion to saying to people, thanks very much for phoning us, but this is not a police matter, is detrimental on our ability to deliver policing. What I took from that session, as I alluded to briefly earlier, was that I have no confidence in any cop in Scotland watching that will have no more confidence now that these issues are close to being resolved. And it is absolutely my view that whilst we have a partnership, and a collaborative approach in paper, and there has been some good work, I do not feel that Police Scotland can influence that partnership to change process within health for the benefit of policing. So what I mean by that is I do not, and I've spoken to health board CEOs, chief executive of health, GPs, so I would consider myself informed on this. The police have become the default when health can't deal with it. Now, if you look at it from an Article 2 perspective, right to life, police have those responsibilities, so do health. It strikes me, and some commentators have told me that it doesn't appear, or it does appear that health can deal with that responsibility by moving the call onto the police. We cannot do that. And again, I frame all of this around the impact on policing and my colleagues and what the public would expect from a police service in this country. I'm not sure if that answers the question.
It does, but perhaps I didn't understand this correctly. When I pressed the witnesses on, so they explained this competing mental health, so where there's a diagnosis, a mental health disorder, as opposed to emotional distress, is how I would categorise it. And they're saying it's the emotional distress which is the gap. And I felt they were saying it's not an NHS issue.
I mean,
it's not a policing issue, but it's not an NHS issue either. So it's no one's issue, really.
The example we're given of safe spaces, and when I listened to that, it took me back to my time where, safe spaces were available for that tea and biscuit, I think it was, analogy that was given, where, the police, if it was them, could take members of the public who were drunk or whatever to a facility where they'd be looked after. But lo and behold, the funding for these places was lost and they've closed. So that's, that option is gone. But if I'm blunt, if I'm candid, if I may be, these issues are not for the police. I think everyone in that session previously was clear about that. They weren't sure I agree with you whose issues they were, but they are not for the police. Mm-hmm. And whilst we absolutely have a role to play in maintaining the well-being of our communities through keeping people safe, once we get to that point where it is clear that it is no longer a police matter, that is the challenge that we have in passing these individuals on to the right people to care for them.
So, thank you. Now, you said, in answer to Sharon Derby, you talked about second and third line managers and risk positive. Mm-hmm. What do you mean by that? You mean when the call comes in the first place, whether it's through 999 or 101, don't know where they come from, that you think that line managers could make different decisions here to divert?
I know they could. I'm one myself when I was operational, and I speak to many dozens who are afraid to make risk-positive decisions about people who are going through a health crisis for fear of the Perk or the Crown, being subject of criminal investigations or through internal processes with professional standards that we have in the police. And I'll give you an example that I think articulates. There was a young female down in Dumfries who went into the sea. She clearly had major health issues. Took her to a medical facility, and I'm told that health deemed that she couldn't be dealt with there. So the police sat with that individual for 4 days. 2 cops, 4 days. And then the disposal that the police decided was relevant was to drive that individual to Northumberland. Now, if we had confidence in our processes and clear strategic direction from the Chief Constable, we would be making different decisions about that instantly. Because no one within policing wants to lose that resource, to deliver services. But we accept it because of the paranoia that exists around making risk-positive decisions in this area. And that will be playing out across Scotland now and every single day since this issue has been raised, I can promise you. And it takes me back to that point, and I'm sorry for repeating myself. It impacts on our ability to do what we're good at, and it impacts on the health of colleagues who suffer the consequences.
So really, rather than all this work that's going on, which is needed, right? So we've made some progress. You think that's not enough? That Police Scotland itself and the managerial side need to make different decisions in the first place?
We need different strategic direction, in my opinion, and that is the opinion of the cops who I represent. This situation has not changed, and I do not believe that Police Scotland can change it in isolation, and I do not believe that the impetus and the priority that is placed on this work within Police Scotland is replicated across health, and the decisions that have been made within Police Scotland have not been replicated across health to allow us to free up the demand that currently exists in our services.
Thank you very much.
Thank you. Rona Mackay to be followed by Jamie Hepburn.
Thank you, Convener. Good morning. I want to ask you about the health and well-being of your members in Police Scotland. When we did our previous inquiry, we heard not very encouraging news about how things were dealt with, and your own submission is actually quite alarming in parts about how police are able to cope with the trauma that they experience on a daily basis. There was also an issue with the counselling service that your officers were being directed to, and I can't, forgive me, I can't remember the name of that service at the moment, but it was basically around the one-size-fits-all kind of issue that, regardless of the level of trauma that a police officer has experienced, they were being directed to this this service. And I was wondering if there had been any improvement on that front, and also if you think at the moment your officers are being provided with the correct level of mental health counselling.
Okay. I think, first of all, again, I'll acknowledge that, I genuinely believe that work is ongoing at the moment to address, most of the issues that were raised, off the back of that survey that we did. Yeah. But I can't say that without saying that the situation should never have arisen in the first place. Police Scotland has acknowledged itself that, its focus and its investment on, training and keeping people well has not been where it needed to be, and we're now dealing with the consequences of that. It was mentioned by the convener at the start, the levels of sickness that we have, in percentage terms, the information I have is that we run between 7.8 and 9% of absence, in police officers across the country. I also think it's relevant to say that when you read information that comes from the service through its own staff surveys, that the distinction is not always made between police officers and police staff when you look at percentages that are given. The ones that I did were for police officers. I've said in the submission, I think it's worth saying again, our roles are different. When you look at giving people training and information to stay well and have those, the ability to identify challenges within their colleagues and deal with the inevitable trauma of policing, only 3 in 10 from our response of police officers said that they felt that they'd had that training. So there is a huge amount of work to do. The training that is provided to keep officers well is not uniform across the service. There is far more emphasis on probationer training, and even within that programme, I believe that there are areas of duplication that would free up capacity within that programme to allow different aspects of training to be given. What I see for first-line managers, so I'm talking about sergeants, in my opinion, the most important role within policing, because you get it from the bottom and from the top. Yeah. The focus and the provision of training for that rank is nowhere near where it needs to be in numerous areas, but particularly in respect of the identification of health challenges. These can be within policing and out with. We cannot forget that police officers are affected by social issues as well. So that is a huge area of focus. In terms of the offer from Police Scotland, there is some positive news there. I'm told now that 120 colleagues a month are engaging for the first time with counselling services within Police Scotland. Now, you could look at that as a really stark figure in the sense that it's a big number, but I try and look at the positive in these things and say that we are starting to identify colleagues who need help, and the number I have, that 89% of those colleagues take benefit from that intervention. So that is positive. Yeah. But in terms of the more broader elements of identifying trauma upstream, so it's inevitable, the old figure about 400 to 600 traumatic incidents during your career versus 3 to 4 in normal people's lives is relevant. It is inevitable, and we have much more to do to identify a clear strategy and provide training, because a lot of the information exists. It's just that we're not training people and allowing them the opportunity to understand what that information is and how to deal with it. And the model that Police Scotland has approached to its delivery of training, which is largely online, there are exceptions obviously, but fundamentally it's online, and that is simply due to cost pressures. It doesn't work. Cops will come up with many ingenious ways to look, to show on a computer screen that they have done something and tick that box, which is the phrase I hear more than ever, or more than any other in this area, and it doesn't ensure that we are fundamentally understanding the information that is being provided to us. So that commitment and that resource that is needed to train everyone, but fundamentally focused on sergeants. There is no first, there is no second line manager training for the inspecting ranks when you go beyond that into superintending ranks. These are huge issues if the expectation is that those managing the masses, i.e. constables, will have some positive impact on them.
Yeah, no, that's really interesting. You said, I think, was it 38 years service you've had?
20, no, I'm not 28. That old now. 28. I
couldn't remember if it was 20 or 30.
I joined when I was 5.
Apologies.
No offence to you.
So in that time, so obviously you were in it as a young lad and worked your way up.
Very young.
So, I mean, you must have seen huge changes. And in terms of officers' mental health and your own and, you know, all your colleagues, how have things changed for police today in that sense? Because were these services more available? Obviously, online wouldn't have been available, you know, back in the day. But you know, do you feel you were better prepared then than officers are now?
I mean, I tend to look forward, not back. But you know, just to answer your question. For example, when I got promoted, there was a 2-week residential course for, you know, newly promoted sergeants. That's one area that has gone, and one area that I think, you know, needs to be revisited. The challenges of policing, I don't think, have changed. You know, we still dealt with pretty horrific things every day. We still dealt with, you know, there are different challenges now, protest activity, that type of stuff that wasn't there before. The awareness, I think, of mental health and mental well-being is far greater than it ever was before. But I think. If I try and merge the two areas of this discussion together, the ability that I had when I was a young cop in Aberdeen, or a newly promoted sergeant in Aberdeen, to manage my team, to have those peer-to-peer interactions with colleagues, to know that I had, you know, colleagues close by to assist me with whatever it was, that is the biggest change that I see. And that lack of peer-to-peer support, and that, you know, because we've closed over 140 stations in, you know, within Police Scotland, some quite rightly, there's no question about that, but I cannot accept that these decisions are not largely based on finance and the pressures that exist within the service financially. The biggest thing that needs to change where we are right now is the focus, this is my opinion, is the focus needs to return internally. We need to switch the lights on inside and start to look after ourselves so that we can get more cops back to work, so that we can provide a greater resource to deal with what it is that we should be doing. When I talk to communities, I talked to a community council yesterday, they say that the police aren't relevant. You know, people who would fundamentally have been on the side of the police are now not bothered. We cannot get through, you know, to report crimes. I spoke to people in Kirkland Orkney yesterday who told me that, you know, the police station is never open and they wanted a view on that. These are effects not only of the financial pressures that the service are under, but our ability to deliver policing, because we are simply tied up so much of our time with other activities. The 80% figure that I give about operational impact came from Inverness. You know, so in that area we are losing. It's a staggering figure to me that we would lose that much, and almost accept it within policing. It has become the norm, and that has a real impact on the health of people. So
that's a fundamental change from, you know, 2 decades ago when you started out. It's just increased and not.
Well, demand has gone up, resource has gone down,
Yeah,
and
that's
you know,
right.
policing and I don't suggest for one second that police doesn't have the back of its officers, but the focus has been allowed to shift away from policing to the servicing of mental health provision due to the word well-being, in my opinion, and that fundamentally has to stop. The police, in my opinion, have done everything that they can do to play their part in this partnership and this collaboration to deliver change in the way we do policing, and it simply has not been met by partners to effectively allow that change operationally.
Okay, thanks. Just one final question, if I may, Convener. The impact of the new employee assistance programme and the new occupational health service contracts. Do you want to say anything about that? Has that made a difference?
Yeah, I mean, I think there are still challenges. You know, the provision is better than it was for sure. You know, when you look at officers going through ill health, the timescales for that particular process has increased. You know, there was a blip during COVID, obviously. Yeah. We are aware, and, you know, one of my colleagues within the Federation, that is her area of work, but she was able to provide me with some information that said that this process is taking too long, and some of the disposals from that process have concerned us in respect of retaining officers within the service. But I would need to be able to have the opportunity to give you a sort of written response to a particular question rather than kind of making it up here.
That's absolutely fine. Thank you. Yeah. That's been helpful. Thank you.
Thank you, Rona. Jamie Hepburn.
Thank you, Convener. Good morning, David. You obviously listened into the last session. Interesting follow-up on some of the area that I was exploring. You've already touched on that in terms of, I think you set out one of the main challenges in terms of when officers take a person into the hospital environment, looking to see if they can get assistance, being around maybe the lack of appropriate clinician expertise or personnel. But one of the things, and I thought it was an interesting point that was made by Dr. Steele in our last session, is that certainly he has encountered, and it's been reported to him, that some of the challenge committee, and I wasn't saying this in a critical sense, I should say, but some of the challenges might also be at Police Scotland end in terms of protocol that I'm sure have been put in place for good reason, and that clinicians might be saying to individual police officers, look, you've brought this person to hospital now, we've got this person, they're in the hospital environment, we can now deal with this, but for whatever reason the officers themselves are either saying they either don't feel they can leave the person on their own, or they're being told not to leave the person on their own. And I got that was in the wider sense. I mean, clearly there'll be circumstances where that's sensible, the person might have committed the crime and so on and so forth, but this was including instances where that wasn't the case. I suppose in the first instance, can you say, do you recognise that as an issue? And if you do, can you speak to that a lot more in terms of what any of those processes might be and if they need to be looked at?
I think, fundamentally the answers I've given before, answer your question. We have this situation where I do not feel that, supervisors who make difficult decisions every day about all sorts, are applying the same, risk aversion to the decisions about people. So the cover your back scenario is take that person to hospital or wherever, because we simply will not make that decision ourselves for the fear that I spoke about earlier on. Interestingly, the one about missing persons always comes up. We don't leave people at hospital because we're scared that they'll go missing and harm themselves or whatever. And I think that is a real consideration, but I'm not aware of any data that suggests that we have left individuals in hospital and they have then gone on to become missing. Now, I think from a policing perspective, this pilot in J Division is, an initial step. I have seen the document just for the first time last week, and, I think there are real challenges with it. But we have got to start to utilise the technology that exists. We are now in possession of body-worn video. We have handheld devices that we can record electronically decisions that are being made to expedite the decision-making from within policing. So how that might play out would be, Mr Hepburn, you're at the hospital now, are you fine? This has all been recorded. Yes, I am. The police are now leaving. Do you have any issues at all? No, I don't. See you later. That's a very simplified, example of what I think could eventually happen within policing. But again, that example that you give...
Sorry, can I just ask there?
Yeah.
I mean, you've posited my name, so let's just use that name. Yeah. In this scenario, am I the person you brought into hospital, yes, or am I the clinician who has said it is
You would
safe?
be the person that we'd taken there.
That's fine. Please carry on.
Thank you. But again, in that example, and every other one that has really been discussed, it's still predicated on the police taking that person to that facility in the first place, and to tie it back to the well-being aspect of the legislation. And it was mentioned earlier, is it, in the benefit of somebody's well-being to sit with the police for an extended period waiting on a decision through the pathway, or, a decision from DBI, or a decision to take someone to a health facility? Is that good for that person? And the answer clearly has to be no. And I find it frustrating that, we try and sell success, or I try and hear of the selling of success in this area of policing based on the fact that the police have still taken that, initial course of action, which can take hours. And the example, just to illustrate it further, if I may, when you talk about Woodlands has been spoken about down in Ayrshire, it's a tremendous facility, a clinic, a facility within a hospital to deal with people who are going through, unscheduled mental health crisis. The numbers that I have is that 1,200 incidents have been dealt with down there, 1,100 of them successfully. They have a 72% referral rate from the police. So you think that that is a success and that will take demand away from the police. But when you ask about the impact of the 100 cases that couldn't be dealt with by that service and what that impact was on operational policing, it wipes it out. So from an operational perspective, we are no better off than we would have been previously. Do you know what I mean? So it is a challenge, but I think the solution, and having listened earlier, I am even more resolute in that opinion, is that we have got to start doing things differently in the police, because there is no prospect, in my opinion, of this broad situation changing in any time soon, and that if we don't, we will just continue to have this discussion in 3 years' time, as we did 3 years ago when I started in this job.
It sounds to me as though part of the equation here, because you've taken the person to hospital, presumably because you think, well, that's the environment that they're going to be safest in, and that's the appropriate place to go. And understandably, an officer, they're accountable to, and they take their order from their superior officer, the supervisor, as you've described. But if the qualified clinician as saying, you know, it is now safe, you've brought the person here. How do we get to a place whereby, and you sort of describe it as, you know, almost, and I can understand the human instinct in any profession, you know, I've got to cover my back here, but how do we get to a place where people, officers, including supervisors, and it sounds as though they might be the key player here from what you're saying, are confident enough to say, I've now been told, or you know, the officers on the ground have been told by an appropriately qualified medical professional, you can go now. You've brought them to the right place. You know, what needs to be done, do you think, in that to get there? Because it does sound as though you're saying, you know, some of the issues are at the operational end of Police Scotland.
Yeah, and you know, it's very, very simple. You give, you know, police officers the confidence and the structure from the top to make those decisions, and be confident that, you know, if that person does subsequently leave the hospital and, you know, complete suicide or harm themselves, that they quite rightly will be scrutinised for the decisions that they have made, but that they won't be, you know, the subject of extended processes and periods of investigation to the PIRC. And these might be appropriate, but it is that fear that prevents that, what I can see you consider to be fairly basic decision-making from actually taking place. So it has to come from the top. There are many examples from within the PIRC who have looked at, you know, police contact deaths and decided that there was no issue whatsoever with the decisions made by the police. But that culture is not ingrained across policing in Scotland, and it is that fear that prevents that basic decision-making from taking place.
Okay, thank you.
Thank you. Final question from me then, just to sum up some of the evidence that you've talked about, Mr Threadgold. You said earlier on, it's leading on from Mr Hepburn's point, actually. You said earlier on in this session, these issues are not for the police, and therefore they need to be passed on. In the first session, Dr Steele told us the NHS don't view this as an NHS issue. So it begs the question, where in your view is the blocker here? What's preventing the handing on? And therefore, who has agency to make this better?
Well, I think as we spoke about at the start, the hook at the moment is the legislation that says well-being and that fear of making decisions that, you know, I would argue would be risk positive for the benefit of policing. You know, police will make operational and instinctive decisions in every set of circumstances that they find, but if somebody is clearly going through a health crisis, I'm not sure that anyone, and certainly no one at the table that I was at, which was full of, you know, health professionals, academics last week, when these case studies were presented, agreed that any of them were the role of the police. So if you accept that, you know, what we're being presented with as evidence has nothing to do with the police, from within policing, from out with policing, then, you know, there has to be process within the public sector in Scotland to afford a mechanism that allows people to stay well and to get the help that they need. Extended exposure to the police is not that for that individual, because we're not trained to deal with it. And any suggestion, you know, that we should receive enhanced training to be able to identify and deal with those going through, you know, some sort of medical crisis, we would strongly argue against that, because unless that's what the public want, it is not our function. You know, the analogy is that you have the fire brigade policing, you know, at Pittodrie because, you know, somebody, you know, they might as well just do it. But that is the situation that we have at the moment. You know, you don't see the fire brigade in surgical wards, you know, performing operations because it's not their role in the public sector, you know, jigsaw. But we have found ourselves picking up so much of the function. And the thing that frustrates me the most, I think, at Convener is everybody acknowledges it. You know, it was acknowledged, you know, one of the speakers, I think Dr Steele, offered his sympathy to police officers. We don't want the sympathy of the NHS. We want an effective public sector that allows us to play our part in the delivery of services across Scotland. And at the moment, we're hamstrung in doing that for all the reasons that we've spoken about.
I understand. Polly McNeill would like a quick extra.
Thank you. But that's what the committee, in the submissions, that's exactly what the committee are reading, as you said there, which is that seem to be going the other direction, training up police officers for doing that, some of that work. But it's just a final question. It just occurred to me because I have dealt with this myself. In 101 cases, probably, I suppose, where a person's in distress and they're not answering the door, a police officer would need to go in case the door needs to be broken down. So is that the kind of risk or assessment decisions you're talking about? Because I see the need for a police officer to attend that call because no one else has the authority to kick a door down. Would that be right?
Yeah, I mean, you know, the first function of the police is to preserve life. You know, we're always going to do that, and we're always going to attend, you know, emergency calls, whether they're road accidents or members of the public on the street who are going through some sort of health crisis. You know, we will go there in that situation. My view is that the handover, as has been discussed, between us and health is either broken or non-existent, and it's that is so inhibitive in policing. Okay. So, you know, a sort of call like that where, you know, you are unsure whether the person is alive on the other side of the door, of course it's appropriate that the police would, you know, would go to that incident. But, you know, if you play out that scenario, it's what would happen next would be, you know, of particular interest to us if what you found was clearly a health matter.
Thank you. Thank you very much.
I'm very grateful. Mr Threadgold, thank you very much for your evidence this morning. One area of our inquiry which we haven't managed to get to was around police suicides, which is clearly very important to us, but we've been stymied by time. I wonder if you might be amenable to writing in on that matter after this session. Would that be okay?
Of course, yeah. If you just let me know exactly the question that you wish to be answered, I'll certainly do that.
I'm very grateful. So we'll have a short suspension until 11:53 to change over witnesses, please. Good morning and welcome back to the Justice Committee. I now welcome Assistant Chief Constable Katrina Payton of Policing Together and Nikki Page, the Temporary Director of HR in Police Scotland. You are both very welcome to our session this morning. We have up to 60 minutes for this session, and I'd like to start by inviting ACC Payton to make a short opening statement.
Thanks, Convener, and good to be here this morning and grateful for the opportunity to share with you again in my role as Assistant Chief Constable for Policing Together, and particularly in my role in leading and supporting the organisation in relation to our policing of mental health demand and how that also impacts on our own staff. You may remember I gave evidence here a year and 1 month ago, which was just ahead of the launch of the framework for collaboration, which I know has been mentioned today. And during that session, I gave an overview of the work that we had been doing across the organisation to reset and rebalance policing's role and responsibility as it relates to policing mental health. I foolishly set myself a deadline at that last session. Through my optimism, I said that if I was here in a year's time, the real test would be what is the tangible progress that has been made. So we are 1 year on, and the question remains what has been progressed. Clearly, for the benefit of time, there's only a few things that I would want to emphasise by way of this opening statement and leave the rest to the questions of this committee. But I think it's important to reflect all of it within the context of policing, because that brings, and the role of policing, because that brings us that understanding and reassurance that our activity is focused where it should be. Police Scotland in April becomes a teenager, and as you've already heard from this session, on our creation we also had the Police, Fire and Reform Act. And you've also heard and actually drawn out the importance of our purpose, which is to improve safety and well-being. 2 small words, but they describe a vast array of activity in relation to place, personal and physical safety. But I want to be really clear to this committee, particularly because it's also been mentioned this morning, that to understand our purpose, you need to do that through the lens of our role. And that legislation is also clear on our role. Our role is to prevent and detect crime, it's to maintain order, it's to protect life and property, and it's to bring offenders to justice. That's our core purpose, that's why we exist, and that is what the public expect of us. And when you look at what does core mean, it means the basic and most important aspect of what we do. So when we consider what we do in relation to policing, it is through the lens of not just our purpose, but also our role. Our Chief Constable has provided greater clarity on that through our 2030 vision. She has been really clear that the role of policing, and as we move forward, is to make sure that we have safer communities, that there is less crime, that victims are supported, and that we have a thriving workforce. We also heard this morning that discussion about who owns it. Where does some of this challenge around mental health demand sit? Let me also be clear to this committee. Mental health is a health, not a justice problem. Yes, of course, there are complexities and there is multifaceted. But people in mental health distress or crisis require care, compassion and sometimes clinical intervention. They do not need control, criminal courts and convictions. That said, the behaviours of people experiencing mental health distress and crisis do require policing to have a role and a purpose in that, because of course our responsibility is to protect life, and so we will always deal with threat, risk and harm. But when that threat, risk and harm has subsided, when there is no longer a threat to life, policing must be able to step back and return to our core purpose, which I have outlined to you. And obviously it remains that there is still, you heard it this morning, a significant proportion of incidents where officers are tending and they are not best placed to either attend and or certainly to remain with individuals without it impacting and being a deviation on our core purpose. So when the crisis is over, we need to be able to return to that. Our Chief Constable has also been clear we cannot continue to fill the gaps. So we've committed, as you know, a significant amount of work to readdressing the balance of our policing response in relation to that. I will be able to draw out through the questions some of the progress being made, because that's the exam question, and I'll be happy to do that. But I also want to be clear that much more needs to be done. And again, I will be able to provide examples of that. And I just want to finish, because you heard from David Threadgill by saying, ultimately, Policing only exists when our officers and staff are thriving. That is why thriving workforce is one of our key elements of our vision. Therefore, our commitment continues to develop the process, the practice and the interventions that make sure that our staff continue to feel well when they come to their work and that they're equipped to do the job that we're asking them to do. And I thank you for the time to give that submission.
I'm very grateful to you. Pauline McNeill.
So, and that's exactly why this committee are conducting the inquiry. But the truth is, there really isn't much progress. What we've heard this morning is that the witnesses have said there's a gap exists and that's fallen to our police force to fill, and that's what David Redgold said. So would you agree not very much progress has been made?
So I wouldn't agree that not very much progress has been made. The progress has been made. And I get, and what I also said last year was that nobody has a magic wand in this, and we do need patience and perseverance to see this through, and we need hope. So it's important that it's recognised that progress has been made. And we've given some examples, and I understand from what David Threadgold had mentioned that the frustration may be that policing shouldn't be even called in the first place. So if we take the mental health pathway as an example, over 15,000 referrals from police, calls that police would have gone to, are now being diverted to NHS 24. You know, that equates, and again we were talking about hours, to 76,000 staff hours. Success in the mental health pathway will be when we don't have any calls to divert, because people know to call 111 and not 101. So there is more to be done in that regard, Pauline. But in the same token, you look at DBI, we have an opportunity to refer people into you know, the DBI services across the country. There are actually 2 local authority areas where we still need to see that mobilised in practice. But it has been mentioned, we have referred, policing alone has referred 7,000 people. Why does that matter to policing? Because actually the evidence shows that when people are referred into that system, we reduce repeat and we reduce escalation. That's important, that's progress. The mental health index, when I spoke to you the last time, that is now in practice across the country. The challenge is, and it was already mentioned this morning, the inconsistency of that practice. So more needs to be done. And there's been progress against the collaborative commitments. But again, more, much more needs to be done. And that much more needs to be that recognition that if we agree it's not police, and what, therefore, are we doing in terms of filling the gap? Now, Dr Steele gave you the example around clinical requirement for that assessment and intervention, and that kind of 80% that don't require clinical. But it's still health. It's still, you know, elements of it are a health issue. And just for clarity, because you mentioned, Convener, one of the statistics earlier around about 14,500 calls or mental health incidents that we attend each month, and 85% of them don't involve an element of crime. A lot of them will still have a policing purpose of, you know, a missing person, a suicide intervention. So there are still a lot of things that we go to that police absolutely should be there. But your point is absolutely right around more needs to be done in relation to the transfer of care and the strengthening of local provision that is available 24/7 across the country. You heard good examples the last time I was here, and the progress in that regard is not as fast or as progressive as certainly I or others would want it to be.
So David Threadgold said that he talked about second and third line managers could maybe make different decisions here. Talked about risk positive. I mean, do you agree with that, or what's the barrier to that?
So I think David did reflect his views and his perspective on that. And one of the things I've been really clear on in my role in leading this work, having policy strategy, you know, guidance is one thing, how is that translating into practice at an operational level? So part of my work since I last met with this committee is to go round, and I've personally done visits to every single division, to sit down with their senior management teams, to understand the practical implications of the work that we're trying to do as it relates to mental health and the barriers. And actually what David mentioned are some of the narrative that comes through around that fear of you know, making a decision that then results in. That's been explored, and my position is we have absolutely been clear with line managers that they have both the authority and the responsibility to make those decisions and to step away when it is safe for them to do that, because the person no longer requires a policing response. That happening on every occasion, I recognise, you know, we still have to continue to do more. But one of the areas of work that is drawn out even in the collaborative commitment is about our training. And we've been given our officers and staff learning bites in relation to a number of things linked to mental health. And the next two that will be going online relate to risk assessment and transfer of care. So further to the discussions and the empowering that we're trying to give our supervisors, our staff and our line managers, supported by our guidance, supported by our strategy, is ongoing training and ongoing support so that they do make those decisions, but they make them knowing that they're doing it with the support of the organisation.
Thank you very much.
I'm very grateful, Pauline McNeill. Thank you for your contribution this morning. I'll take the next question, then I'll move to Sharon Dowie. So, ACC Payton, the Federation also said that there was an ever-increasing demand on Police Scotland to look after vulnerable people for ever longer periods, and that's in a context of resource going down. So what does the Chief Constable propose to do about that, and might the right care, right person model that we heard about earlier be part of the solution?
So I'll take that in reverse order of how you asked it, Convener, in relation to what is the Chief Constable going to do about that, and I'll come back to right care, right person in a second. What the Chief Constable has done about that has been really clear in her statement to the SPA that we need to reset the balance as it relates to our policing demand and policing's role in responding to mental health. That's not just been words. She's invested in resources, chief officer level and team of people through the Mental Health Task Force to support us drive forward the practical implications of that and the governance structures, the strategic visibility and awareness, and has invested in systems to provide us insights and engagement, so our mental health dashboard. So the Chief Constable has been really clear around the need for us as an organisation to shift that balance, and she remains utterly committed to seeing the progress that we need. And as I've mentioned earlier, policing is doing all that it can and continues to work with partners, but we need to see more progress in some of the other areas, and I specifically mentioned transfer of care and strengthening that local provision. You mentioned right care, right person, and we spoke about that the last time I was here, and the reality is nothing has changed, and I'll tell you why. Right care, right person, when it was brought in, yes, of course, gives the option to step away, but I've mentioned a piece of legislation that you've mentioned as well, Convener. We have a responsibility to police in a way that's collaborative, and that's part of our core purpose and our core role, and that's critical because, again, actually, in mental health, it is multifaceted. No one service has the answers. So policing's been really clear that we will not step away until there's an alternative and there's safety in that alternative when there's a risk to life. And that's why, and as I mentioned the last time that I was here, we've been down, we've had a look at right care, right person. Anything that we think would add value has been brought in to our organisation. But that's not the right model. And some of the evaluations of some of the right care, right person down south has shown that to be the case. So we are comfortable that the model that we've got through the Partnership Delivery Group, through the work that we're doing, through the framework for collaboration and the collaborative commitments, is the way forward, is about everybody playing their part. But of course, as I mentioned, we do need to see swifter progress in some of those other areas.
I'm going to bring Rona Mackay in a second for a quick supplementary, but since you brought it up, ACC Payton, this Section 32, this well-being issue. Now, you talked there about, or you talked earlier about the core role And you set out, I think, 4 policing priorities. You talked about the 2030 vision, and the Chief Constable has the safer communities, less crime, victim support, and crucially the workforce. But we heard the Federation talk about this Section 32 earlier on, and they said that was the key issue, that because there's well-beings in there, it's fostering a culture of that's risk-averse, and an expectation that I think you've just said the public don't necessarily have of the police. Now, if that's right, and if the Federation are right that there's a different strategic direction needed from the Chief Constable, and unless that well-being issue changes, nothing is going to change, it begs the question, how does Police Scotland respond to that? And what do you think the Chief Constable can and will do?
So this time I'll take it in reverse order and I'll be really clear. The Chief Constable is really clear on our purpose. Our vision sets that out really clearly, and underneath the safer communities, the less crime, the supported victims, the thriving workforce are a number of milestones and objectives that we are working towards. As it relates to the legislation, I mentioned earlier, you know, improving safety and well-being, 2 small words, can have a vast array of interpretations. But here's the reality. If we deliver the Chief's vision, which is predominantly around that safer community, less crime, supported victims and thriving workforce, we do improve well-being. Society thrives and has a positive well-being when you have safety and you have a justice system that is fair and equitable. So it matters. It's a byproduct and it's relevant and it's important. But it's about, and I said before, it's about understanding the lens through which we understand improving safety and improving well-being. In the same way, there are aspects of safety that are not for police to deal with. You only understand what it means in that act around improving safety when you look at our role. Deter, prevent crime, maintain order, etc. It's not necessarily elements of water hygiene safety or whatever else, because that's not part of our role. So in the same way, when we're talking about improving well-being, it's through the lens of our core role. If we do the things that the public expect us to do, we will see improved well-being. The challenge has been, and I absolutely acknowledge that, Convener, the challenge has been that sometimes that can be misinterpreted by others, that policing does have a role to perform. And what we are saying, and that's why the Chief was really clear from the start of our time into Police Scotland, that we need to reset the balance and we need to reset the parameters in relation to policing's role as it relates to mental health and mental health demand. And just to finish on the point about the demand, again, just to put it into context, you heard from David earlier about the number of incidents and that 1% reduction. Now, that's still progress. But I think, again, if you set it in the context of the year previous to that, there had been a 4.5% increase. Then not only have we stabilised that and we're seeing the reduction, there is progress being made. But I go back to the point that I made right from the outset, much more needs to be done, and that's why the Chief's committed to having further engagement with our NHS Board Chief Executive and others to start to move much more into those areas that we spoke about, and I know you explored in quite a lot of detail with the first members around transfer of care and strengthening local provision.
I understand. So just to reflect that back then, and these are my words, so
Okay.
if I'm not reflecting it correctly, do challenge me. You would argue that the focus, or to focus on well-being under Section 32 is actually, it's a red herring, it's the wrong end of the telescope, because what Police Scotland would say is that you achieve the well-being piece by the day-to-day operation, and that's the outcome, rather than say, and perhaps there's been a misunderstanding, that well-being has been part of the day-to-day operation. What the Chief Constable wants is to make it an outcome rather than a day-to-day.
If you're looking at it, but we still have a role in well-being in relation to, for example, and I've mentioned some of those incidents in relation to threat, risk and harm. So someone, for example, who is suicidal, you know, that policing still has a role in that, and the role in that is to keep them safe in that moment. So there's a very direct, you know, transactional response for policing in relation to that well-being. The same would go when we're dealing with children, where we're maybe not preventing or detecting crime, but there's a very direct link to improving well-being from a threat to life perspective. But what I'm saying is, no matter what, you can't. My personal opinion is the two go hand in hand. If we do one well, you know, well-being certainly is improved, but there are times where we still have to focus on well-being. There might not be a crime, and that comes back to the point I mentioned earlier. A number of our incidents that we attend don't have a crime related to it, but it's still right that police attend, because it might be a missing person, as I say, might be someone who's suicidal. There might be a whole range of elements that don't require justice, but they do require police.
I understand. Rona Mackay to be followed by Sharon Dowie.
Thank you. Good morning. Good morning. I just want to. You've talked about resetting the balance in relation to mental health duties that you're performing. So, what we're gathering is that what you're saying is progress has been made, but there's a lot more to be done. We've heard from David that the balance hasn't been reset because you know, your own figures show that 85% of call-outs didn't involve a crime, so it was mental health issues. So clearly that's an issue that needs to be resolved.
Can I just
of course
those figures as well? I think it's helpful to say that. One point of that is that even though it's not a crime, there can be a requirement for police, you know, to still, because there's a threat to life.
No, I heard you say that, and where suicides, attempted suicides involved. I do understand that. You did say too that success could be measured when, you know, you don't have to take any calls about mental health issues or distress, whatever. And so, you know, in your opinion, would like a public awareness campaign be good for, like, who do you call if you're having an extreme mental experience incident? Would that help so that the public knew? Because I don't think the public, you know, the first as a first responder, they would maybe phone you, but if they could be directed to, maybe if this is what's happening and you're not threatened or being threatened, you could phone this other number. Would that help?
So that's why number one of our collaborative commitments is about communication. Number one and two, there's 19 collaborative commitments that sit within the framework for collaboration, and the first two relate to communication. And so yes is the short answer, and yes, that's work that is being progressed.
I mean, I'm thinking,
in partnership.
Thinking more in terms of a government public awareness campaign. I'm not thinking of an internal thing, you know, because that's how people get to know about it. You know, you're talking about stuff the public won't have a clue what you're talking about, frankly, because of all the collaborative interactions. They don't know about that. They just know about if they hear something on the telly or they read something online. That's who they would call. You know.
And so our communication plans has already started doing that. So even when I was speaking to BBC in December, quite clearly mentioned again successes when the public know to dial 111. So and we can continue to expand. But I think one of the things that we need to do, which is why the collaboration element comes into it, we need to work at a pace and a scale where if people phone that number, it's going to be answered and there's a resource to speak to it. So there are, as I know you will appreciate, there are a number of, you know, elements that we need to make sure we would, you know, as a general society, irrespective of where we are, raising
to be fit for purpose.
Exactly. And just on that, you heard about our mental health pathway and the calls that are being diverted. One of the other elements that we're doing, and it touches on to what David said, is we're, you know, looking at other ways where we can have, you know, voice messages to ask people some questions that they then know to phone 101 to hang up from the police number and phone 101, but also for us to say, if we're quite clear that it's not, but they don't want to go to the mental health pathway, that we hang up anyway because it's not a police thing. So there's a lot of things that we're doing to try and address what David said at that first opportunity. Are we giving ourselves the best chance to say this is not for police and stopping it at that point?
Thank you. So you've mentioned the phrase thriving workforce quite a lot. Would you say that the workforce is thriving at the moment?
So my answer, as a strategic leader, my answer is until 100% are thriving, then my answer to that is no. And the reason why the Chief has it as a part of our vision is because it's critical to us being able to deliver our service. Nikki, as Head of HR, will go into some of the practicalities of that and some of the outcomes from our survey that tells us that there are, again, green shoots of hope, that some of the work that is being done is starting to have an impact on our staff. So.
Okay, thanks. Nikki?
Thank you, and thanks for the question. So just to answer it straightforwardly, we've got a lot of work to do, and we appreciate that. And as ACC Patton has outlined, there's an absolute strategic commitment to it, and it has kind of 3 levels to it. There's the prevent aspect of it, the support aspect of it, and then obviously there's the restoration, where we've already got people who need far more support because they're already ill. In terms of that prevent aspect to it, we've got that kind of primary focus on barriers in the workplace, and we are listening to our workforce to say what are those barriers. There's numerous barriers, but the predominant one is resources. That is a factor that obviously is mentioned in our submissions. It's been mentioned by David, so that's something we can't get away from. However, what we can do, and what the Chief Constable is focused on, because it's in her gift, is how we look at barriers and how we create capacity within the resources we've got. And how she has done that is working with partners to reduce court abstraction. We've seen the benefits of that in things like re-rostered rest days. That's an absolute hindrance factor of our workforce, because obviously if you get disruption in your rest time, that's your recuperation time, so that is not good. So we've seen a drop of about 10,000 within that space, which is the green shoots of hope.
Sorry, when you say a drop, what do you mean by that?
But in terms of those re-rostered rest days, right, they're coming down. So our requirement to change somebody's day off is reducing, because we are managing with partners things like court attendance, other things like that require us to re-roster officers and bring them in their time off. So that's one positive aspect. The other aspect of it is we have big events, all of these sort of things that require that front line capacity to be there. And the Chief has commissioned work that looks at us remodelling our workforce so that we can put more people in the front line during busy times to relieve some of that stress and resource complaints. So there is absolute internal work in that primary stage going forward to try and support the workforce and answer that question of what you're doing about resources for us. And there's an absolute commitment. And actually, I would say that this Chief has done far more in that space than I've seen in the kind of 13 years before. In terms of the next stage, which is secondary, that's that individual support. And I noted your questions earlier to David around about has that improved? Yes, it has. So we have focused on a number of improvements. We are doing far more in terms of training and lifelines. We're now training our probationers as they're coming into the service. We're making them aware not just of trauma in its widest sense and how they support society, but also what trauma means for them. David mentioned police officers are roughly exposed to 300 to 400 serious incidents of trauma in their policing career. That's based on a 30-year career. Of course, the pension changes means that our workforce are working on beyond that, and therefore they are exposed to more trauma. So our ability to manage that, make them aware of that, and get into that prevent space is an absolute focus for us. And the place that we are pushing into in that is the trauma impact prevention technique. Now, previously, and we use trauma risk management processes, or TRIM, that you've probably heard of. They're used across not just policing, but armed services. That's about after the incident and how we deal with that and how the officers coping after that. The prevention part of it is kind of upstreaming it and saying, how do you deal with a traumatic incident and how can we give you tools in your toolbox to manage that better so that it has less impact on you. So a big push into those areas. Engagement with the workforce too, again, it's that prevent, do you understand where your mental health is at, doing mental health assessments for them. And while we've got good engagement on that, having introduced it, we've still got indicators that show that we've still got to push into that and do more work. So, for example, those that come out red in that assessment, they're almost all going on to get support. Those that come out amber in that assessment, we would like 100% of them to say, well, I need to engage further and do more in this space, but we're sitting at about 50% there. Now, some of that relates, and it came out in the survey that the Federation did, relates to that stigma. You know, do I want to undertake further support? So the support's there, but do I want to undertake it because I'm scared what colleagues or others might think? So we've got a lot of work to do in that, but we've got significant communications in this space and push into that space. And by tackling training probationers in this space, we're normalising it for their workforce at the inception of their career. While I think if you're looking at officers, and I'm looking to you now, Kat, who have got 30 years more, at the inception of their career, they wouldn't have been as trauma aware as they are now. They wouldn't have been aware of that whole life journey of looking after yourself for 30 years that we are now trying to ensure that our new workers are. And there is a gap, frankly, between officers who have longevity of service compared to new probationers, and that's the gap we are trying to close as well.
Are you able to tell the committee what the sort of dropout rate of, or the retention rate of new probationers is? Is that improving? Is it going backwards? Or?
So national patterns of retention show that between 3 to 5 years, that's the kind of risk component. And then if we can get people over 3 to 5 years, there's a kind of storm plateau of that. So at the moment, I think Scotland's got one of the best rates of retention at that 3 to 5 years across policing in the UK. However, what I would say with an ageing workforce and a reducing working population, we will be competing to make policing attractive. So we know that we have to ensure that policing is a career that...
I was really trying to get at whether that was improving, that situation, or whether you're getting more dropouts, basically. That's what I'm trying to get at. And if you don't know numbers, if you can just give me a...
I would be able to provide you with those numbers after the committee, if that's helpful. It's certainly, there is small numbers, I would say, in that 3 to 5 years percentage rise. But what I would say to that is it's extremely small numbers. So I wouldn't want to say that that's statistical pattern or give false assurance in that. However, it is something that we keep a very close eye on for the reasons I've just outlined. We have to remain attractive. And the applications within to policing suggest just now, certainly in comparison to colleagues in England and Wales, we get far more applications to join policing in Scotland. So it seems to still be an attractive career.
It's the retention element.
It's really the retention element, yeah.
Because, obviously that comes down to whether or not we're going to have enough police officers in the future.
Absolutely. And I will provide those figures after the committee.
Thanks. Yeah. Convener?
Very grateful. Before I move to Sharon, to be followed by Katie, we are starting to run out of time. So if I can ask colleagues to be very tight on their questions, and witnesses, if you can be similarly concise, I'd be very grateful. Sharon Dowie to be followed by Katie Clark.
Oh dear. Right. So how can Police Scotland improve the handover at hospitals? So that's the kind of initial one, but also to possibly not take the call in the first place. And I know that there's various things that we've talked about phoning 101, but you actually said if there's no threat to life, you must be able to step back. So how can you improve the handover, and what is it police officers are scared of to move away? Are they risk averse? Are they scared that they won't get support from higher up officers? Is it if something was to then happen, they would get the blame for it? How can we improve the handover, and how can we improve the confidence of police officers to actually leave someone who's not a risk to life?
Thanks for the question, and to try and be brief. So Well, we're obviously focused in this area, which is why the pilot's going on. You've heard about that. So that's one element. What are the practical, mechanical elements that will support some of the decision-making at a practical level, so that officers and staff have the confidence to do that, that part of it? I've mentioned that we've been very clear around, you know, line managers and supervisors make risk assessments every day, and part of that is to understand, is there an ongoing and enduring risk, and if there's not, and we have fulfilled our responsibility up until that point, then we should have the confidence to step away. What will help that is the things that I've mentioned around continuing to empower people, continuing to deliver training around risk assessment and transfer of care, so that some of that decision making is helpful. That said, policing is a caring profession, and therefore you know, two things can be true at the same time. It can be true that, you know, we should walk away, but there's an element where people are still wanting to make sure that that person is getting the right care. And if you're in an establishment where, and you heard that this morning, for example, NHS are thinking, well, that's not for us at this time, then that's the gap. And it's that gap that we collectively and collaboratively need to address with opportunities through some of the work around the safe spaces. You've heard of other places where people can go that are in mental health distress, as opposed to police having the responsibility to pick that up. So it's a combination of all of those things that we will start to see the progress being made. The pilot that went on in E&J Division finished yesterday, the 17th, and it's been evaluated, and so we will be looking at the practicalities of rolling that out. And early indications and anecdotal evaluation is saying that that is saving a number of hours. It doesn't stop the reality of staff having to attend in the first place. They have attended and they have taken the person there. That comes back to some of the improvements that we need to see, for example, in the mental health index. So it's inconsistent across the country. In some areas, the staff will always get access to a clinician and assessment and be able to step away. Other areas, they're being told to take a person to A&E. So there is the inconsistency. We're highlighting that with partners. I'll be at the Partnership Delivery Group next week. We need to see consistency of practice. I was heartened to hear the Director for Mental Health mention that they're going to review the Community Triage Mental Health Index to see where it's working and what more needs to be done, because we certainly need to see that consistency across the country.
So it's still confusing then, because you've said if there's no threat to life, we must be able to step back. But you also said that you cannot step away until there's an alternative. So that's basically tying the hands of police officers that won't be able to go and step back then. So what would you like to see NHS doing right now that they could implement right now that would actually help you?
So just in terms of the context of that statement, where we're talking about right care, right person, so we were talking about the approach. So what I was saying at that point was that we wouldn't, you know, devolve our responsibility in, you know, protecting life and supporting people in crisis when there's not an alternative to do that, because no matter what, and we will encounter people in mental health distress or crisis in a whole range of scenarios, whether it's domestic situations, you know, whether it is criminality, whether it is missing people. So we still have, and my position on that is until there's an alternative, we don't step away from that element of responsibility. Where we get into, we've got someone and we've taken them to an E&E department for whatever reason, where we are in a position that we are comfortable that that person is safe, then we want to be able to empower our staff to be able to step away. And that can only happen, and here's the thing, we're dealing with behaviours, we're not dealing with DNA forensic kit. So everything is continually being assessed in terms of the level of threat, risk and harm that that person poses to themselves and to other people. And police officers, and this is part of the issue, and you heard this from Dr Steele back in January, you know, police officers, actually medical staff, some medical staff are not trained to diagnose mental disorder. So asking police officers to understand whether someone's in mental health distress or crisis or disorder is really difficult. That's why we need the support of partners to be able to say, we are comfortable, which is why the transfer of care pilots on post, we are comfortable that we now have an understanding of the risk and the person can stay and remain with us. And even if they did leave, for example, there wouldn't be a high-risk missing person, or there wouldn't be an increased risk. And that's the practicalities, and that evaluation will be really important for us to roll out when we have a better understanding of that impact.
So effectively, we're still not any further forward then, because your officer still won't be able to go and leave somebody without there being an alternative. So the NHS still haven't really made any progress then, have they?
Much more progress needs to be done by NHS. There's absolutely no doubt about that.
It's a health issue.
Absolutely no doubt about that.
Right. Okay, thank you.
Well, Katie Clark to be followed by Jamie Hepburn.
I appreciate that we don't have a huge amount of time. On the retention issue, it would be helpful if you could give us quite a great deal of detail on that, because it is concerning, both the fact that the numbers of police officers are dropping, but also recent statistics show that some quite young police officers and police officers with not many years' service seem to have left disproportionately. So it would be helpful to get an understanding of that over a wider period of time, whether that's changed over, say, the last 10 or 20 years. And if you're able to provide that detail when you're right, that would be very, very useful. I was wanting mainly, however, to ask about the work that's happening with other agencies and individuals other than the NHS, because a great deal of the evidence today has been in relation to the National Health Service and transfer of care, and, if you like, what happens perhaps in hospital or other similar settings. But clearly, many of the scenarios that the police have to deal with are not in those settings. So could you perhaps say a little bit more about what work is being done now, whether other agencies or individuals, to ensure that the police are able to transfer individuals outside those kind of settings? Because there's been quite a number of mentions of other agencies and other partners.
So I'm assuming you're referring to things like the NUC?
Well, I'm really asking what you mean and what work you're involved in. So I don't want to make a presumption. I'm asking really what... There's obviously a wide range of other agencies, and perhaps you could see some of the work that you're involved in. If you want to talk about the
So
NUC,
we've got the Partnership Delivery Group, which brings together Scottish Government, it brings together local authorities, it brings together other emergency services, and it brings together the third sector. You've mentioned, and of course that includes, in terms of emergency service, that includes our NHS colleagues. A big part of what we need to work with is with NHS 24 through the mental health pathway, etc.
And you've spoken about that, yes.
So, but what we also need to do is linking to the point that Dr Steele spoke about, is about who else is best placed, if it's not NHS, who else is best placed to consider the support that's available. And so through... we also have, in support of the Partnership Delivery Group, a Partnership Reference Group, where we have third sector and lived experience voice that lets us understand wider support that's available. That work, through the Framework for Collaboration and through the collaborative commitments, is supporting understanding alternatives to A&E. So, and I mentioned one there, things like the NUC. So the NUC in Glasgow that was just opened, with more to open, is a new walk-in centre. So people experiencing mental health distress and or crisis can walk in to that service, and they immediately get the support. It's a place where our officers in Glasgow, for example, can take people with mental health distress that isn't E&E, and it's an alternative. So we are working to understand the benefits and the implications on that for policing in terms of reduced demand, and a better place than an A&E department for somebody to understand, you know, what they need in terms of what has caused that distress, and the support that's available. And there are examples of that across the country.
Yeah, so I appreciate we don't have a huge amount of time. In terms of proportion then of the types of scenarios that we're talking about, how many do you believe really are non-NHS that really the police should be able to hand over? And it's not, the NHS isn't actually the right people, what proportion, just to get an understanding, just because so much of the evidence has been about the NHS.
So there's
how much would you say?
So there's a couple of
things.
The couple of things I would mention in relation to that. Part of the work of the Partnership Delivery Group and the Framework for Collaboration is the creation of a performance framework, which will pull all of that together. So we've got a draft performance framework that will look at a whole suite of measures, including you know, the time, the response. One of the things I think is really helpful for this committee was what actually Dr Steele said in the same session I was in with him in January, when he said that about 80% of those who go to A&E are not clinically requiring NHS.
Yes.
So that would suggest that 80% require some alternative. And we don't have sufficient alternatives and consistently across the country, and that was the point I made in January last year, and that's where we still need to see much more support across the country, that there are alternatives for someone that is like your Beacon or your Edinburgh Crisis Centre or your Nuke Point, and those facilities that provide an alternative to A&E.
Okay, I mean, if there's anything further that you want to write in about on that, that would be really helpful. But I know we've got
more
a
than happy
time
to
issue.
do that.
Thank you very much.
Thank you. Jamie Hepburn to be followed by Fulton McGregor.
Thank you. I just want to pick up on the area explored with other witnesses. And you have touched on some of this already, and it's about that sort of bottleneck where officers will take someone into the hospital environment, probably more often than not A&E, and then they have to wait there for, or they feel they have to wait there for a long period of time. And David Threadgold talked about this, sometimes coming from a position of the supervisory officer, the superior officer, maybe not enabling the officers on the ground to leave. And you've touched on the ACC. Is it Payton or Patton? Payton. Okay, that's what I thought it was. ACC Payton, you said officers and staff should have the confidence to leave a person if they, in the case of a hospital or where they're comfortable, they should be empowered to. We heard very directly from Dr. Steele, and I don't know how frequent an occurrence this is, but he was talking about the circumstances in which a qualified clinician is literally saying to officers, you can go now, you've brought this person to this place, it is safe to leave, yet for some reason they won't do it. And I suppose that begets the question, if officers have taken the person to the hospital, they presumably think, at least in the first instance, there's a possibility this is the appropriate place to take them, to leave them in the care of someone with that professional expertise. At what stage does the officer not feel, well, that's enough for me, I now feel confident this person who understands mental health challenges better than I do is saying I can go, but why are they not leave? Why are they not then thinking, well, that's the juncture at which I can leave?
Well, again, I would need to understand the individual cases, because what I would be saying, and be assured, I've been, as Nicky's mentioned, I've been a police officer for 35 years, and I remember the scenario as a hostage and crisis negotiator, where we would take people, that we had been speaking with, who were contemplating suicide on a bridge to A&E at that time, in those days, because it was a number of years ago, and we would be told, you can leave them, but they're not going to be getting an assessment. We're quite comfortable and you can leave. We would still be reluctant to walk away, because you've just spent hours with somebody on a bridge, protecting their life. It's really difficult decision making that happens. I also get that
speaks to human instinct. I think that is an understandable human instinct. But we're also talking, if we're hearing, right, the challenge is that officers are then not able to divert to other forms of activity we would expect them to. I suppose it's how do we get them to, and it's hard, but to move beyond what would be an understandable human instinct, say, well, I've got a job to do, so I now need to trust this person who's told me I can leave, so they can then do so.
And I couldn't agree more, which is why our focus is on equipping and empowering, which is why, as an example, I went round and done all the divisional visits to make sure there's nothing lost in translation around what is the expectations of us, as an organisation. Why, supported with our guidance, we are doing the learning sound bites, which specifically are looking at risk assessment and transfer of care, so that we are giving people that confidence to be able to say, you make decisions in this way, and in these circumstances you will have support. The sad reality, of course, that we all know is people may choose to take their life, and that's horrendous, and we want to prevent it. But police officers have to be able to be in a position where everything that has been done and in their gift, and being able to give that support and walk away. Now, you've mentioned a scenario, but if that scenario is brought to my attention, that's one where I'm able to say, let's look at that and let's give support. What would change that? And so, like I've said from the outset, we don't have a magic wand where overnight we will change behaviour. That's been a pattern of behaviour both for our officers and both partners overnight. But are we starting to see progress? Which is the question for this, of course, committee. You know, I've been clear that yes, there is progress, but I've also been clear much more and quicker progress needs to be done in a number of areas.
I just wonder if it's a case of how you actually make it structural. You know, that this there must be a way of recording, saying, well, I've been told I can go by a... And
that's part of that transfer of care. So you're doing a collaborative risk assessment discussion, you know, and you're agreeing as a collective. You're happy to take, we're happy to give, and we walk away. Because we also covered the consequences, the what if, which is the one that is concerned. What if they leave? Well, even if they do leave, we are agreed. There is no... And that gives us a really... And it's not the answer, because remember, this is a sum of all these parts, but that starts to give confidence to staff that they have something tangible that allows them to be saying, I did everything that was in my gift.
OK. That's helpful.
Thank you. And finally, Fulton McGregor. Fulton, you're on.
Yes, that should be me now, thanks. There's a slight delay, just thank you, convener. Thank the panel.
Fulton, can I ask you just to start again? Your connection's really bad. Can you start the question again, and we'll have to move on if you're remaining unclear. If you start again.
Okay, thank you. There doesn't seem to be any Wi-Fi problems here, but thanks, convener. You hear me better now?
Yes, I can.
Yes. Okay, thank you very much. Yeah, my question is very much on the themes that have already been explored today by others, and that is around about the joint up working. And I wanted to dig into that a wee bit further because I asked about it in panel 1 as well. Because it strikes me that there's quite a lot of situations where we're hearing that maybe NHS services or other services, perhaps social work and others, are saying that this isn't really for their remit. And the police, and we heard from David Threadgold as well, who said there's a lot of situations where that's also not police, and that's diverting police attention away. Is there an argument for an assessment phase for workers to go out together? Because you can see there's lots of situations where there may be a risk, and that is then therefore appropriate for the police to be there. Whether the actual situation itself is a police matter after that or not might be disputed. But I wonder whether there needs to be more work done where assessment is actually carried out by both police and other services, just let's say health in this particular scenario. Is there work being done there to do that? And what form is that taken? Or is there more that we can...
Thanks for your question. And again, just keeping it brief. Yes, that is something that is considered, and we've got options around work with the triage cars in Dundee, at Glasgow, and I think Edinburgh's at the 3 locations at the moment, and trying to understand if that again continues to help, because we're doing joint assessment and understanding of risk, and all of these interventions and opportunities form part of as I say, the partnership delivery group, where we're able to understand and evaluate, and particularly important is what's the impact of that, and therefore is it something that we would want to scale up or scale down depending on the effectiveness of it.
Or are you done?
Yeah, no, I think convener, in the interest of time, I'm quite happy with that. I mean, obviously we've had 3 panels today, and it's quite a big area, but I think happy enough with that, convener. Thank you.
Yeah, I'm grateful, Fulton. I appreciate your consideration there. So that concludes the evidence for this morning. Just for committee members and for your own purposes, ACC Peyton, the committee will seek a written update after this on how progress is going on tracking whether work-related stress and mental health contributes in cases of police suicide, just like we were talking with Mr Threadgold earlier, because I think this was explored in the previous session that you were at, and this wasn't data that was being tracked at the time. We'll also want to know what improvements have been made to the duty of care system for officers and staff. But we'll be in touch about that following this session. So with that, that concludes our marathon evidence taking for this morning. I thank everyone, all the witnesses that have attended this morning, everyone who's attended and asked questions, and we'll now move into private session. Thank you very much.